Good afternoon, Dr. Ravi. And Dr. Abhijit is also there, Dr. Abhijit.
Good afternoon.
So finally we got you, Dr. Ravi. For last, 1 week, you are a bit busy, very, yeah.
Yeah, there have been a lot of activities.
Yes. Okay. I'm just, we'll start by, say, 1:30. I'm just waiting for Dr. Jiloha.
Yeah.
And I'm just calling and let him join. Okay.
Very good afternoon, Ravi sir.
Yeah, good afternoon. How are you?
I am fine, sir.
Yeah, that's good to hear. Sir, good afternoon. Good afternoon, sir.
Good afternoon, Dr. Jiloha. We are very thankful that, you are joined to, motivate we as a juniors in the fraternity. It's about 1:29. We'll start by 1:30. We are waiting. We have two options actually. The people are watching it on a live streaming on medskill.in. And those who are interested to join into the meeting room in Zoom, so they are joining. So we have 8 participants now. Maybe people are watching on live streaming on medskill live. So we just wait 1 or 2 more minutes, and then we'll start. We'll start by introducing our chief guest of honor for today, Dr. R.C. Jiloha. And then Dr. Jitendra is our moderator for first session. So I'll pass on to Dr. Jitendra. And then the first speaker is Dr. Ravi Gupta.
Good afternoon, Ravi sir.
Yeah, good afternoon.
Yesterday, Dr. Nishant has, delivered on child and psychiatry. I think you are aware about him. Actually, he did. I think he's. I think you are aware about. He's a psychiatrist in CIP, Central Institute of Psychiatry, Ranchi. Dr. Ravi will take one or two more minutes. We'll join in and we'll start. We won't wait because people are watching on live as well. So here we are just getting that 10 participants in Zoom meeting room. Dr. Sanjay has already also joined. Good afternoon, Dr. Sanjay. Please unmute your phone or device.
Hello.
Yeah, Dr. Sanjay, now you are audible. Yes.
Just a sec.
Yeah, it's audible now.
Hello.
Yeah.
Hello.
Yeah, you are audible.
Okay, that's fine. Great. So, how is it going?
It's going good. We have Dr. Jiloha is already joined. He is with us. Dr. Ravi, the first speaker, is also with us. Our moderators are there. Organizers are there in the meeting room. So we are, just starting now.
Okay. I'll just ready my presentation and keep it on then. Huh?
Yeah. So first, Dr. Ravi will speak and then your turn. I'm just, starting. Yeah.
Yeah, sure.
So good afternoon, all participants. This is Dr. Nurul from National Health Academy, New Delhi. We are not-for-profit organization working in medical and dental education and taking the importance of sleep medicine. We have we have spoken to many sleep specialists and all, and we get the idea from them to organize this program on occasion of World Sleep Day. And we have a galaxies of speakers we have experienced yesterday as well. Today we have again the experts who's who in sleep medicine. So to start with, we have our guest Dr. R.C. Jiloha. He is not he is known to everybody, but we are just making our formality to introduce him because the old fraternity he is in a practice in psychiatry for last more than 45-46 years. So the people knows him very well, and we are very grateful that he has spared his time and he is joining. He's now with us. Just to give brief introduction, Dr. Jiloha did his graduation MBBS from Medical College Rohtak. Then he did his MD Psychiatry from prestigious PGI Chandigarh. Then he is WHO Fellow in Addiction Psychiatry from University of California. And he did fellowship in Child Psychiatry from University of British Columbia from Vancouver, Canada. So he is having 45 years of experience. Currently, he is working as a consultant in Paras Hospital, Gurgaon. And formerly he was associated with prestigious medical college, Maulana Azad Medical College. He served there as a director and professor and head of the psychiatry department of psychiatry, Maulana Azad Medical College. And he also served as a head and HOD department of psychiatry in Hamdard Institute of Medical Sciences. So without taking any much time, I just request my guest, Dr. R.C. Jiloha, to address, because we are we have in our audience budding medical, the people who are just going into the field. They are graduates, SR, JRs, they are, junior faculties are also. So we want that, you just motivate us, give your patronage support so that we can, make whatever, the endeavor is to make this sleep medicine, we want to, make awareness among healthcare professionals and all the fraternity in graduate as well as PG, UG, SR, JR in all, specific departments like psychiatry, neurology, physiology, pulmonology, ENT and all. So over to Dr. Jiloha.
Thank you, Dr. Nurul, for your lofty introduction. I am really impressed the way you describe things. Anyway, good afternoon, friends. I believe Dr. Manchanda is there. And
good afternoon, sir.
Yeah, and other members of the organizing committee, learned speakers, and the delegates. It is indeed a proud privilege for me to be the part of this very webinar, because this is for the first time it is happening in India as a National Sleep Congress. As all of us are quite aware of this fact that World Sleep Day is an annual global event which is being celebrated for quite a few years now worldwide, just to create an awareness about sleep issues which include medical, educational, and social. In India, it is happening for the first time. That is very important to me, particularly to be the part of it. Well, friends, it started yesterday, and actually I should have been there yesterday only to share my thoughts, but because of some limitations, it was not possible for me to participate yesterday. But since it is magnanimity of Dr. Nurul that he accommodated me today to share my thoughts. Well, friends, you all know it very well that due to its restorative, adaptive, and behavioral capabilities, sleep is a noble physiological phenomena bestowed by the nature to us. It is not only important for our general health and qualitative life, it is also playing a significant role in our growth as well as in aging. There are three crucial elements for a good qualitative sleep, that is duration of sleep, continuity of sleep, and the depth of the sleep. Since the theme of this year is quality sleep, sound mind, happy world, this phrase itself tells volumes about how much sleep is important in our day-to-day life. So the objective of this particular gathering, I believe, is to minimize the adverse effects caused by sleep disorders in the society, as well as to explore management and preventive aspects of sleep disorders. Sleep problem is prevalent all over. It is a global epidemic. Almost 45% of world's population has one or the other sleep problem, and having its impact, adverse impact on one's health and quality of life. Most of the sleep problems are preventable or at least treatable, but because of lack of awareness among the population, among people, just 1/3 of the total sufferers seek professional help. So that tells the volume of the gravity of situation, that it is so important, this webinar is so important in the Indian context, to let people know, and even the professionals know, the magnitude of the problem and the adverse impact on the quality of life because of this handicap. So it becomes very important. So since the theme of this get-together is related to mental health, so mental health and sleep are linked very closely, and they have a bilateral relationship, a reciprocal relationship, which we may call as a snowball effect. Sleep influences the maintenance of our mental health, and mental health is the key to the quality of sleep. So both are interrelated. When one of them is a failure or is not in a good shape, the other is inevitably affected. For a healthy mind, quality REM sleep is essential. All of us know it. I'm just sharing my thoughts on this, that during the REM sleep, dreams are more intense and they are quite vivid. And the brain is active during this period to process emotional information, particularly the positive emotions, which pave paths to a healthy mind. But when it is too little REM sleep, that generally favors consolidation of negative memories. And when there is a consolidation of negative memories or negative experiences, that leads to the disturbed state of mind, leading to mental illness and particularly depression. During the sleep, as night proceeds, REM sleep becomes longer and more stable. That's why it is very important for an individual to have adequate sleep. So adequate sleep is very important for having a quality sleep and in turn having a quality life. Anxiety is one leading factor which disturbs our sleep. Anxiety causes hyperarousal, and because of hyperarousal, there is a racing of thoughts about previous day's experiences or about the agenda of tomorrow, and that racing of thoughts causes anxiety, and there's a hyperarousal, and thus there's a sleep disturbance. So sleep disturbance is a condition which is directly associated and present in almost all psychiatric disorders. So you can see its importance in psychiatric disorders, and those who are suffering from chronic insomnia or chronic sleep problems, they are particularly at risk to develop anxiety disorders, depression, and other psychiatric problems. So the poor quality of sleep not only causes psychiatric disorders, there is a negative influence on the immune system, hormonal regulation, metabolism, and even cardiovascular system. So the body itself on the whole gets affected. Sleep deprivation is definitely detrimental, not only for mental health, but also for the physical health. And we have a galaxy of speakers who are experts in their own particular fields. So we have an opportunity to listen to them, particularly about the psychiatric problems. We have Dr. Ravi Gupta. I know him very well for quite some time, and he has been working on sleep for a significant period of time. And he is a very devoted person in this very particular area. Dr. Manchanda is a very well-known figure in the field of medicine, particularly with sleep, and he needs no introduction. We have others like Dr. Sapna Sridharan, Dr. Colonel Abhijit, and Dr. Shaikh, who are experts in their respective fields. We will be glad to listen to them. And particularly, I'm thankful to Dr. Nodal for giving me this opportunity to be the part of this very important program. And I believe that in future also, every year, this is the starting year, in every coming year, we will have this kind of interactions, exchange of thoughts, and create awareness in the society to minimize the problems of sleep, explore the preventive methods, and manage effectively those who are suffering from it. Once again, I'm thankful to all the organizers for giving me this opportunity, and I am eager to listen to all the speakers. Thank you very much.
Thanks, Dr. R.C. Jiloha. Thanks for sparing your time and coming to our platform on Nascon 2022 and sharing your thoughts and all. Now I am passing the responsibility of moderation to one of our colleague, Dr. Jitendra Kumar. He is a assistant professor in Department of Psychiatry, Jawaharlal Nehru Medical College, Aligarh Muslim University, Aligarh. And from here, he would be, moderating the show and take you through the whole webinar. Over to Dr. Jitendra.
Thank you, Dr. Nur sir. First of all, thank you so much all the attendees and participants for investing your valuable time with us for NASCOM on this Sunday afternoon. Today, we have eminent and amazing speaker and guest with us. To begin with, first topic today is sleep and psychiatry. But before I introduce the speaker, it's my honor and privilege to introduce before you Dr. Ravi Gupta sir, who will be talking first on this topic, that is sleep and psychiatry. Dr. Ravi Gupta sir is working as additional professor in the Department of Psychiatry in AIIMS Rishikesh. He is also in charge of sleep medicine in AIIMS Rishikesh. Sir has done his MBBS from Jawaharlal Nehru Medical College, Ajmer, and MD Psychiatry from Sawai Mansingh Hospital in Jaipur. Sir is among very few psychiatrists in India to do PhD in psychiatry. He has more than 200 research articles in both national and international journals to his credit. He is pioneer and well-known figure in sleep medicine in the world today. Now, I hand over the platform to Dr. Ravi Gupta sir and urge him to enlighten us on this topic. Dr. Ravi sir.
Thank you, Dr. Jitendra, Dr. Nurul, and Dr. Jiloha sir for this opportunity. Next 25 minutes or so, I'll be discussing the relationship between the sleep and the psychiatric disorders. So we will first look at the evidences what are the evidences which connect the sleep and sleep disorders with the psychiatric disorders. We will look at the possible mechanisms why these sleep problems or sleep disturbances and the sleep disorders, they are common in patients having psychiatric disorders. Then we will see the interaction between the sleep and the psychiatric disorder. And there are a number of psychiatric disorders, they have sleep disturbances, particularly the insomnia or the hypersomnia as one of the symptoms. Then we will look at certain sleep disorders which can masquerade the psychiatric disorders. And then I'll summarize the whole of the discussion. So if we look at the evidences, it is very common and almost all of us know that whenever we are stressed or anxious, we are not able to either initiate the sleep or do not get the good quality sleep. That means that deep sleep or the depth of sleep is not perceived. Now, when we look at the relationship between the insomnia and the depression, insomnia can precede the depression. It can occur during the periods of depression. And in a number of patients, it was earlier known as the residual symptom of depression, but the current evidences suggest that this is not a residual symptom of depression, rather a comorbid insomnia, which often go unnoticed. Now, patients who are having schizophrenia, they also report difficulty in falling asleep and say rather than having the actual insomnia, what they complain is a change in the shift of the sleep-wake cycle. So most of the patients of schizophrenia, they usually go to bed late at night and wake up late in the morning. And lastly, if we look at the patients with the addictive disorders, particularly the alcohol and opioid, insomnia is common, especially during the phase of withdrawal. If we look at the other evidences which was published in the Psychological Bulletin in 2016, you will come to know that the anxiety disorders, eating disorders, the ADHD, and then personality disorders like borderline personality disorder, autistic spectrum disorder, they all these patients, they complain of difficulty in maintaining the sleep. Similarly, depth of sleep, as Jiloha sir has already mentioned, that we need a deep sleep, restorative sleep. This is also lowered. And the pressure of the REM, that is the occurrence of the REM and the duration of REM, it is increased in number of psychiatric disorders. If we look at the obstructive sleep apnea, which is one of the most common sleep disorders after insomnia, then the literature suggests the different prevalence of the obstructive sleep apnea among patients with schizophrenia, schizoaffective disorder, bipolar disorder, major depressive disorder, anxiety disorder, and post-traumatic stress disorder. And these prevalences have varied depending upon the method for the assessment of the OSA, the age of the patient, population of the patients, and the medications that they were given for the management of the psychiatric disorders. Now come back to the basics, and I think this was discussed yesterday as well. So just a recap that the sleep initiation goes with the interplay between the circadian and the homeostatic mechanisms. So for the homeostatic mechanisms, we have certain nuclei in the brainstem, especially the monoaminergic nuclei. So these nuclei, basically they project to whole of the cortex and they keep us awake, alert, aroused. On the other hand, we have the ventrolateral preoptic area, which is in the hypothalamus, and this projects the GABAergic signals which inhibit the ascending reticular activating system signals. And once these nuclei are inhibited, then we actually fall asleep. So this is basically the part of the homeostatic process of the sleep. Second, we have circadian process, and we all know that we are the diurnal species, so light induces the wakefulness in us. So light travels through the retinohypothalamic tract, reaches to the suprachiasmatic nucleus. From suprachiasmatic nucleus, the signals go to the pineal gland, the melatonin is released, which again sends signal to the dorsomedial hypothalamus. And this dorsomedial hypothalamus gives the activates the VLPO. So we fall asleep as when we are in a state of darkness, that is by the evening. Now, when we talk about the melatonin release and the activity of the VLPO, this is basically controlled by a circadian clock. So almost all cells of the body, they have these circadian clocks, and these circadian clocks are regulated by one master circadian clock that remains in the suprachiasmatic nucleus. So it's a feedback mechanism where some proteins, they inhibit or degrade their own products, which an accumulation of these products, they actually inhibit the expression of these proteins. So it is basically a feedback mechanism which allows us to follow a circadian schedule and a timely sleep. Besides light, there are other Zeitgebers, that is the determinants of the sleep, which entrain our suprachiasmatic nucleus. And these Zeitgebers are food, reward, social engagement, social activity, punishment, sex. So they also act as a Zeitgebers, and they actually help us to synchronize our sleep and wake timing every day. The issue is all these Zeitgebers, they are regulated by the different parts in the brain. For example, the emotions, they are basically regulated by the amygdala and basal thalamus. Then we have the VLPO and GABA, which actually inhibit the orexin neurons. And then the feeding cues, which are basically dependent upon the serum glucose, the amount of the ghrelin in serum, and the leptin, they also influence the secretion of the orexin. And we all know that orexin signals from the posterolateral hypothalamus, they send excitatory signals to the ascending reticular activating system, and they keep us aroused, awake, and alert. So this is how the Zeitgebers, they work, either to induce the sleep or to keep us awake. And importantly, when we are engaged into any kind of social activity, that actually influences the activity of the amygdala. If we are in a state of fear or terror, then the activity of the amygdala increases. That actually sends the positive signals to the orexin, and we face difficulty in falling asleep. Same thing happened with the food. So the message is sleep disturbance and the sleep disorders, they are common in the patients who are already suffering from the psychiatric disorder. Sleep is regulated by a two-process model, that is the circadian as well as homeostatic. Both the processes, they interact in not only functionally but also anatomically in the hypothalamus. And besides light, there are a number of other Zeitgebers which help us to entrain our sleep-wake cycle every day. Now, second question is why the sleep disturbances are common in psychiatric disorder? Four possibilities are there. First, both the sleep disorders and the psychiatric disorders, they share the neurocircuitry. Stress, which is common in any of the disorder, and that too in psychiatric disorder as well. So it also regulates the sleep-wake cycle. Then the genes which influence the circadian cycle, they not only regulate the sleep-wake rhythm, but they also influence the occurrence of the psychiatric disorders. And lastly, the sleep disorders, they can masquerade the psychiatric disorders. So we'll examine each of them one by one. So when we talk about the shared circuitry of the sleep and the psychiatric disorders, you would find that the most commonly we implicate the activity of the monoaminergic nuclei which reside in the basal forebrain as well as the ascending reticular activating system for the occurrence of the psychiatric disorders, because they project to whole of the cortical areas. And most of the medications which we give for the treatment of psychiatric disorders, they also act or alter the activity of these nuclei, of course, at the postsynaptic level. So they help us to treat the psychiatric disorders. And we have recently discussed that the sleep is also regulated by the ascending reticular activating system. So the sleep as well as psychiatric disorder, they have a gross overlap of the neuroanatomical and the neurophysiological structures which govern the occurrence of both. If we look at the stressor, so we have already discussed that stress leads to the arousal of the cerebral cortex and prepares us for the fight or the flight reaction. It also activates the amygdala and basal nucleus of stria terminalis, which in turn sends signals to the orexin neuron. Orexin neuron regulate not only the ascending reticular activating system activity, but also regulate the number of other physiological parameters like respiration, cardiovascular activity, body temperature, the pain, and all these things together, all these systems together prepare us for the fight or the flight reaction. So the stress, under a stressful situation, the activity of the orexin neurons, it increases. Similarly, the activity of the cerebral cortex also increases. It's a two-way process. The orexin neurons, they also activate the ARAS, which in turn sends signals to the cerebral cortex, besides the direct effect of stress on the cerebral cortex. And that is a reason that we are not able to fall asleep or maintain the sleep when we are stressed. If we look at the genetic level, so it has been found that certain genes, for example, the 5-HTTLPR, which actually governs the activity of the receptor for the serotonin, so it also regulates the anxiety or the anxiousness, which is known as the neuroticism, and also it has been found to influence the predisposition towards the anxiety, depression, as well as insomnia. So because of the shared genetics, both the disorders, they often co-occur. If we look at the stress and the psychiatric illness, it's basically a kind of chicken and egg situation. We do not know what comes first, whether the stress or the psychiatric disorder. But we know that when we look at the stress, then and the psychiatric disorder, so they have the common genes. They share the neurobiological underpinnings, as we have already discussed. And some of the psychiatric disorders like anxiety and depression, they are associated with difficulty in falling asleep or maintaining the sleep. So the person remains in a state of sleep deprivation, and sleep deprivation itself is a stressful situation that can again precipitate the number of psychiatric disorders. When we talk about the role of the clock genes, so it has been found that the variants in the PER2 gene, they are associated with the advanced sleep-wake phase disorder. Variants in the PER3 gene are associated with the delayed sleep-wake phase disorder. And we all know that the variants in the clock gene are associated with the evening chronotype. Evening chronotype means the people who go to bed late in the night and wake up late in the morning. And the people who go to bed late in the night and wake up late in the morning, they have been found to have a significantly higher risk of major depressive disorder, bipolar disorder, schizophrenia, addictive disorders, and personality disorders. So this could be one reason why the psychiatric disorders and the sleep disorders, they go hand in hand. Now, when we talk about the clock genes, as we have already discussed, they are present in all cells of the body. So they are also present in different areas of the brain. And in certain areas, for example, the prefrontal cortex, hippocampus, amygdala, and ventral tegmental area, the areas which are important for the expression and the neurobiology of number of psychiatric disorder, their expression in these areas is greater than the other areas of the brain. And it has been found that in patients suffering from the psychiatric disorders that we have discussed in the previous slide, the expression of the clock gene is altered, especially the patients who are having these disorders, and they improve with the management of these disorders. So bottom line is the sleep problems are common in psychiatric disorders because of the shared neurobiology, because of the clock genes and interaction between the prefrontal cortex, limbic lobe, the centers which regulate the sleep, that is the ascending reticular activating system, and the orexin neurons. Now, let's examine whether the sleep disorders, they can masquerade psychiatric disorder. So one of the common sleep disorder is restless leg syndrome, which is characterized by an urge to move legs. And this urge to move legs is often associated with the dysesthesia. So these patients, they complain of either the pain or bubbling sensation or crawling sensation, which are prominent in the muscles of the legs, and in 50% patient also in the arms. They are most commonly reported in the calves, but yes, in some patients, the thighs are also involved, and the arms and forearms are also involved. So these dysesthesias and urge to move legs, they follow a circadian variation. That means they occur only in the evening, or if they are present during the daytime, then they worsen in the evening. These urge to move leg and the dysesthesias, they worsen during the rest when the person is not able to move the legs. For example, when the person is lying on the bed, but any kind of counter therapy, for example, massaging the legs, stretching the legs, or walking or running, they bring the relief in these sensations. Now, this was a study that we published. So we took the 99 subjects from the psychiatry OPD, and their chief complaint were insomnia, generalized body ache, fatigue. So they have been given diagnosis of depression, anxiety, somatoform disorder, fibromyalgia in the past, but they were not improving with the treatment for optimal duration, with the optimal doses of the drugs, and none of them were diagnosed with the RLS. And what we found that a significant number of them, they were suffering from restless leg syndrome. Now, this was another paper that was published in American Journal of Managed Care. So the findings of this paper are that nearly 70% of the subjects who actually have RLS, they report insomnia, which often, and that is the reason RLS often go unnoticed. Insomnia in these patients is either initial insomnia or can present as the multiple nocturnal awakenings. These patients, because of the non-refreshing sleep and the sleep deprivation, they present with multiple comorbidities. For example, anxiety, depression, hypertension, and the untreated RLS, which is often mistaken for insomnia or psychiatric disorders, that poses a huge economic burden. And to worsen the condition, the psychotropic medications are known to aggravate the RLS or at times precipitate the RLS. Now, why do the patients with RLS, they have poor quality sleep? So here you can see a 30-second epoch, which is taken from one of the patients who presented to us in our sleep lab. And here you can see the person is in N2 sleep or stage 2 sleep. And you can see here the sleep spindles, you can see here the K complexes, and you can see along with the minor leg movements which are not visible to the naked eye, they lead to micro arousals. That means only the cortical arousal. So these patients, they often complain of poor quality sleep or a dreamy sleep throughout the night. And these patients, they actually are having RLS or PLMD, but they often remain undiagnosed. So the message is RLS is a common disorder, but it is rarely diagnosed and barely treated. Now, just think of a patient who come to you with complaints of sad mood or irritable mood, complaints of multiple body pains, fatigue throughout the day, low energy. He says that he's not able to concentrate properly, the memory lapses are there. And in the night, he complains of non-refreshing sleep or difficulty falling asleep or difficulty staying asleep, that is multiple nocturnal awakenings. So all these criteria, they fit for a case of depression. Till the time I ask for the history of snoring, snorting, or witness pauses in the breath of the patient by the bed partner, or drooling of the saliva, or sweating, or nocturia. The moment I ask these symptoms and the patient also complain of these symptoms, my diagnosis changes from depression to obstructive sleep apnea. So obstructive sleep apnea, unless properly screened, can masquerade depression, somatoform disorder, and fibromyalgia. Now, among the patients who are having schizophrenia, OSA can occur because of multiple mechanisms. First is the sleep fragmentation, which deranges the respiratory rhythm. Then we have the metabolic syndrome, because the patients of the schizophrenia, especially who are on the second generation antipsychotic, they gain weight, and weight gain is a major risk factor for the emergence or evolution of obstructive sleep apnea. Thirdly, there have been some studies which found that even the drug-naive patients suffering from bipolar disorder and schizophrenia, they are at higher risk of having obstructive sleep apnea for some or the other reason, which is still unknown. Fourthly, the antipsychotics and the anti-anxiety pills which are given to these patients, they also act on the ascending reticular activating system, and these neurons, they also regulate the muscle tone, and the reduction in the muscle tone can lead to emergence of obstructive sleep apnea in these patients. Now, patients with obstructive sleep apnea, this is again a 2-minute epoch from our own sleep lab. So here you can see the person is having hypopnea. That means the depth of the respiration is decreased during the sleep, as you can see here over the green bar. Or this patient has stopped to completely stop breathing during the sleep, as you can see over the red bars. And this is associated with hypoxemia, as you can see here, and also the cortical arousal. So these patients of the OSA, they have recurrent arousals at night. That is the reason they complain of poor quality sleep, and they are predisposed, because of the sleep fragmentation, they are predisposed not only to the metabolic syndrome, cardiovascular disorders, diabetes and stroke, but also the anxiety, depression, and somatoform disorders. If we look at the patients of the insomnia, nearly 50% of them, they also have comorbid insomnia. Similarly, patients with obstructive sleep apnea, they also have daytime symptoms as well as the nighttime symptoms, which are common, and they and in which meet the criteria for the insomnia. So again, not only the psychiatric disorders, but the sleep disorders, they also co-occur. So in summary, what we can say is that sleep complaints, they are intricately related to psychiatric disorders, and this occurs because of the multiple reasons. There is a shared neurobiology between the two. The prefrontal cortex and the limbic lobe, they have an influence on the sleep as well as the activity of ascending reticular activating system. The clock genes, they regulate both the psychiatric disorders as well as the sleep disorders. And a number of sleep disorders, they masquerade the psychiatric disorders. And similarly, psychiatric disorders, they also increase the risk for certain sleep disorders. This is for all from my side. I thank you for a patient listening. Thank you very much.
Thank you, Dr. Ravi, for very enlightening, presentation. You have, taken through all the audience with the various aspects of, psychiatry and sleep, and it was very nice presentation. Dr. Jitendra, over to you. Is there any question from audience, or you can ask your question?
Yeah, sorry, sir, there was interruptions. Sir, there is one question which we encounter in the OPD and all, like we encounter like many young people, they come with sleep problem. Like their concern is when to start sleep medication. When do we start zolpidem? When do we start benzodiazepine? Initially, it has been found that they keep on taking over-the-counter medication like zolpidem and all. Is it right to prescribe medication in initial part, or should we go for any behavior modification and all?
No, actually, I think it is important that you hit the problem when it is starting itself, because if you do not treat the insomnia in the initial stages, because of the process of kindling, actually it becomes chronic. So, of course, we cannot say whether only the behavioral treatment will work, because behavioral treatment, they take time to show their effect. So that should be started, but along with the medications.
Sir, one more question, sir. Is there any role of personality disorder and sleep disorders?
Yes, a number of personality disorders, especially those where we have the high amount of impulsivity and the anxiety, for example, cluster B and cluster C, they are usually having very high rate of insomnia and circadian rhythm sleep disorders.
Sir, and so one last question, sir. Is there any role of sleep disorder and infertility, sir?
Not directly, but sleep disorders have been found to reduce the libido.
Sir.
So that can lead to infertility, but I am not aware of any direct relationship between the infertility and the sleep disorders.
Thank you so much, sir. Thank you, Ravi, sir, for your impressive presentation.
Thank you.
Thank you so much, sir. Now, our next speaker will be Dr. Sanjay Manchanda, sir. Sir will be talking about what everyone should know about sleep and sleep disorder. Sir is the chairman and senior consultant in Department of Sleep Medicine in Sir Gangaram Hospital, New Delhi. Sir has been practicing sleep medicine for last 24 years with more than 23,000 sleep studies to his credit. He is considered to be first in the country to start sleep medicine as an independent department at Gangaram Hospital. Sir is also first to start home sleep studies. He is also first to start somnoplasty for treatment of snoring on OPD basis with the help of ENT surgeons. He is first to start dental sleep medicine in India. Sir has developed the first mandibular advancement appliances for treatment of snoring and mild obstructive sleep apnea in India. Sir is first to start sound and music therapy for treatment of insomnia. Sir is among many times sir first. Sir is also first to start networking of sleep centers across the country and distant reporting of sleep studies. Sir is considered to be excellence in developing sleep medicine by World Medical Council in 2016. Now over to you, sir.
Thank you, Dr. Jitendra. Am I audible?
Yes, sir, you are audible.
Okay. Well, I'd like to thank Dr. Ravi that he covered a lot of it in his lecture, especially of the psychiatric and the insomnia part of it, so it has lessened my burden. So I'll just start with, actually, the thing is, being in the World's Sleep Day, so we will just be moving around a bit, not only confining ourselves to a single domain, but mostly so. Reshaffen once said that if sleep does not perform an absolutely vital function, then perhaps this is the biggest mistake the evolutionary process has ever made. And I think he is so right, because it is very, very important that nature is kind, has not taken 1/3 of lives for nothing. So the thing is, I think it is very important. Let us see the importance of this particular subject. What is sleep? The basic definition, which is a simplistic possible definition, is this is the natural periodic suspension of consciousness during which the powers of the body are restored. So it is simple but effective. And when we talk about the functions, it is essentially the restoration of the mental and the physical faculties, entering information into the brain and basically consolidating the memory, re-establishing communication between various parts of the brain. And also it has, the most important thing is to restore the body energy and repair the body tissues, especially during the deep sleep, or basically stage 3, 4, or now N3. But sleep is still an enigma. And there are, say, still areas of concern which have not been addressed, but they will soon be. But unfortunately, sleep is still not a societal priority. As an individual, we are sleeping around 20% less than our predecessors were doing, sleeping in the last 100 years, probably related to the artificial light. The optimal sleep time, 8.2, where these Americans have typical fetish of pulling up decimal place somewhere. But as say, average sleep for a worker is restricted by 1.5 to 2 hours. So we are clearly a sleep-deprived society today. So is sleep really important? And what does sleep deprivation cause? Let's see certain examples in the history. Well, this is a very old, kind of a figure, which was presented way back in 1995-96 in the United States. And India has got a population which is 4 times more than United States. And even the awareness has increased. So these figures will be much more inflated. That is, there are more than 50,000 unnecessary deaths per year, countless injuries, disabilities, failures, and misery. The accidental costs go into $100 billion, and the healthcare costs, they're going into more than $200 billion a year. As far as the disasters which have happened because of sleep disorders or sleep deprivation, the first is our Bhopal gas tragedy in 1984. 500,000 people affected, 20,000 died. We have been listening to this word Chernobyl nuclear plant in the present scenario with the war between Ukraine and Russia. But the thing is, in 1986, when it was erstwhile Soviet Union, there was the world's worst peacetime nuclear disaster over here, with 3.4 million people affected and half of them children. World's worst oil spill that happened, and the clearing costs was $2 billion and the fine of $5 billion for the Exxon company. And that was the first time National Transport Safety Board of United States declared that sleep deprivation was the cause of this accident. Thereafter, another important thing was in 1995 when a Star cruise ship, Princess, had to be grounded in Alaska with more than 2,000 people. The bottom vessel had ruptured and the cost repairs were $27 million. National Transport Safety Board concluded that the pilot was chronically fatigued as a result of obstructive sleep apnea. Ever since then, there has been a directive that any, say, heavy vehicular movement, any people or persons who are carrying many other people or who are using heavy vehicles on the road, they have to undergo this study so as to understand, okay, they are fit to drive, because it is not only their life at stake, it is the other people's life also at stake. Well, this was basically an overshooting of the mark. The pilot snoozed while landing the plane, killing 123 people altogether. And this is something that we see every day in our daily lives. And the list goes on. The importance of these disasters is not to show the disasters, but the importance is, could they have been prevented? The answer is yes. If we had adhered to certain things and if we had treated the things correctly, maybe many of these disasters would have been prevented. So sleep essentially is governed by the law of 1/3, because 1/3 of our lives we spend in this phase, and more than 1/3 of the population suffers from some or the other sleep disorders during any given time. It would be interesting for all of us to know that there are more than 80 sleep disorders which have been, which international classification of sleep disorders is concerned. The chunk is taken by, of course, insomnia, which has been discussed by Dr. Ravi. And we will talk slightly more about sleep disorder breathing. Otherwise, I would have talked about insomnia as well. And the range is around, it ranges between 2% to 40% in certain subsets. Apart from that, there are hypersomnias, where it could be idiopathic or it could be the result of some underlying sleep disorder. Narcolepsy, which is supposed to be rare or a very little thing, but we have diagnosed more than 200 cases of that in the last 25 years. Circadian rhythm problem, people who are traveling into the different time zones, plus also the call center children, they are also having this problem. Then there are parasomnias like sleepwalking, sleep talking, sleep violence. So there are a whole lot of sleep disorders which are there. And when we analyze the sleep, we should not do it only, at least not in the first phase. We should try and do a polysomnography to find out and don't miss on anything. Well, let us just talk about snoring and obstructive sleep apnea. Well, Mark Twain once said, "Do not ever go to sleep. So many people die there." I don't know why he said it, but the fact of the matter is a large number of strokes occur during sleep. A large number of MIs occur during sleep, and large number of people do die in their sleep. Mr. Bapi Lahiri being the latest one and in the news. So the thing is, it's very, very important for us to understand that snoring is injurious to health, because it is the voice generated by the soft, fluffy parts of the, upper throat, the palate and the tongue, due to the narrowing of the airways. When the air passes through this area, you can vibratory sound, and that is called snoring, which is a cardinal symptom of sleep apnea. Apnea per se means cessation of airflow. And when it is more than 10 seconds at a stretch at the frequency of more than 5 events per hour, it becomes pathological. So then it becomes a diseased entity. Now, as far as the sleep disordered breathing, the broader terminology is concerned, it's a continuum, which basically starts from intermittent snoring to mild chronic snoring to heavy chronic snoring, upper airway resistance syndrome, mild obstructive sleep apnea, moderate and severe obstructive sleep apnea, depending upon the number of times of stoppages of breath every hour that you get. If you have more than between 5 to 15 events per hour, this is mild obstructive sleep apnea. If there is a stoppage of breathing from, say, 15 to 30, then it is moderate, and more than 30 becomes severe category of sleep apnea. And the symptoms are pretty much common. That is snoring, excessive daytime sleepiness, fatigue, irritability, anxiety, depression, poor memory, and poor concentration. There could be reflux, waking up with choking and gagging sensation, morning headaches, poor control of the blood pressure. Ideally speaking, despite being a various subsets, we take it around 6 to 8% today of the population having obstructive sleep apnea. So clearly there's a huge amount of disease under the surface. And right now we are not looking even at the tip of an iceberg. So it's very important that there should be more diagnostic, there should be more people who are aware of this disorder so that we can effectively treat it. As far as sleep apnea is concerned, the pathophysiology, if you look it over here, till the time we are awake, muscles are normal, we are breathing in and out normally. The moment we go to sleep, the muscles relax, the tongue falls back, the palate goes down, and there's total closure, which is broken by the loud snort. The muscles gain their, tonicity, and you start breathing again. Imagine this happening to a person for hundreds of times in a single night. Now, if it isn't treated? What are the complications that are there? Well, I think, yeah, here. Now, the thing is, it is ranging into all the systems of medicine today, and it is percolating in last 40 years. There's a huge spectrum of body systems which are developing this problem. In pregnancy, you can have pre-eclamptic toxemia, premature births, neuropsychiatry, it could be strokes, depression, epilepsy, impotency. In pediatrics, it is attention deficit disorder, sudden infant death syndrome, then seizures and nocturnal enuresis. In cardiology, it could be hypertension, coronary artery disease, angina, and arrhythmias. Socially, it's a big cause for nuisance, especially the snoring, and can cause marital discord. And around 30% of all traffic and industrial accidents, they occur because of sleep deprivation. And sleep apnea may be a good big cause of it. Apart from that, the performance at work and in the school for children, that also goes down. The latest entrants be chronic kidney disease and end-stage renal disease and type 2 diabetes mellitus. I'll show you all of these in just a few moments from now. As you can see over here, these are the faces who are likely to develop sleep apnea. Here is a budding sleep apneic. There's a person with full neck. There's a person, he's a sumo wrestler. And the thing is, there is total, say, no neck at all. But just see this person. The thing is, he's normal weight. But because of his retrognathia and micrognathia, there is a narrowing in this area and could have severe sleep apnea. This is a classical, say, duo of Laurel and Hardy. Ironically, they both died in their sleep. One has typical long face with tapering lower jaw, and other is a typical face for sleep apneic. Now, a lot of people ask me that what is the criteria of a good sleep and how much sleep is adequate? So adequacy of sleep is a function of its duration, timing, and quality all put together. It is like a tripod. So if any of the limb of the tripod is broken, then despite the two things could be there which are in good, say, measure, but still your sleep will not be refreshing. By duration, we means the number of hours, which could range between 6 to 8 hours because different people are wired differently. The timing means the regularity of timing, and the quality of sleep means the sleep architecture where there is non-REM and REM sleep being distributed. And the thing is basically they are allocated some percentage. And if it is going into one direction in a bigger percentage, something else will be compromised. So any of the three limbs, if they are not functioning correctly, then the patient's sleep either would not be there proper, or otherwise it will not be, say, good enough for him to continue in the day. So let us see these things. Hypertension. This was a wonderful piece of work done by Viren Somers from Rochester, Mayo, published in Journal of Clinical Investigation. He added muscle sympathetic nerve activity to this particular thing. And you can see if there's a stoppage of breath, and following that, there's a sharp rise of, say, sympathetic activity leading on to the hypertension, or basically increase in blood pressure, both in systolic and the diastolic limbs. And remember, this is happening hundreds of times in a single night. So this causes a huge amount of hemodynamic instability. Another important thing is congestive cardiac failure. Two different groups, one Matthew Norton, that is basically from Melbourne, and other Zawahiri, that is from United States in Stanford. They came to the same conclusion that 40 to 50% of the patients who have congestive heart failure, they have sleep apnea. Well, this was a work published way back in 1980s, 1981 in fact, where a new radionuclide ventriculogram was done, and sleep apnea was simulated by Mueller's maneuver. And if you can see over here, the ejection fraction of this patient was 43, but got reduced to 33 when Mueller's maneuver was done. So this is basically telling that how heart will be affected over a period of time. Now this is cardiac rhythm disorder. The patient's having missed beats. You can see over here, and extrasystoles as well. The thing is, that is why I request my cardiology colleagues to divide the Holter's monitoring report into the wake phase and sleep phase, If the majority of the problems are occurring into the sleep phase, then the trigger lies in sleep. And possibly we can treat them, and we can also prevent a lot of cardiac pacemakers. May not be much, but still it can be significant enough. Another important issue is strokes. Strokes are caused either as an embolic stroke or hemorrhagic stroke, and sleep apnea and snoring cause both of them. Like if this you can see as a graphic over here. When we are sleeping, the maximum amount of vibration of the snoring occurs next to the bifurcation of the carotids, where the maximum atheromatous plaques are there. So when there is basically a sharp shearing effect over here, it can dislodge a thrombus or an embolus. You can see it over here. And whenever there is a narrowed opening or a narrowed artery, it can clog and cause infarction. Boom. So this can something which can happen regularly. And then there is another aspect of the hemorrhagic stroke. We have already shown that there is a sharp rise of blood pressure with every snoring and snorting cycle. As you can see, this is the snoring, the vibration, followed by total apnea. You can see it over here. And when this apnea will break, there will be a gush of blood because of rise in sympathetic activity, and which will cause basically the weaker part of the artery to burst open and may cause the hemorrhagic stroke. So these are the two ways that it can happen. So it is one of the biggest causes for strokes as well. The new entrant is chronic kidney disease. It was seen that CKD was detected in 30.5% of the cases of sleep disordered breathing, compared to the common screening population of 9.1%. So it was suggested the surveillance of CKD is warranted among SDB patients and vice versa. That is, the patient already has a CKD, that is chronic kidney disease, he should be looked for sleep apnea, because it has been now said by the Association of the Kidneys from the United States that early detection and effective treatment of OSA prevents or slows down the progress of kidney disease. Even if it is to the tune of 5 to 10 to 15%, I think it is important. Now, another important issue is obesity. Like a lot of people feel that sleep apnea is a disease of obese people. It's not always so. Very lean and thin and underweight people can also have sleep apnea. Importance is you do ask the leading questions or the questionnaire that is there. So what came first? It essentially melts down to two hormone therapy, that is the leptin and ghrelin. Leptin is a hormone that suppresses the appetite, and ghrelin is the hormone which increases the food intake and basically has a poor kind of a long-term weight regulation. In sleep deprivation of any kind, of which sleep apnea is one of them, lowers the level of leptin and raises the level of ghrelin. So essentially speaking, OSA and obesity could be the two sides of the same coin. Another important issue is diabetes. 50% of the type 2 diabetes patients have obstructive sleep apnea. And if they are overweight, they are obese, then it goes up to a staggeringly high figure of 86%. It is shown that OSA is independently associated with glucose intolerance and insulin resistance, and it increases the severity of OSA is associated with poor glucose control. Contrarily, CPAP therapy or the therapy for, say, sleep apnea, anything which can help the patient, significantly improves the insulin sensitivity, decreases the level of PP glucose, and improves the HbA1c levels. The relevance is very simple, that sleep apnea in itself is a 100% treatable, near 100% treatable condition. Now, anything which causes hypertension, congestive cardiac failure, cardiac rhythm disorders, strokes, obesity. So the thing is, if you can address so many problems, then treating this at least one variable can at least give us a lot of good thing for the patient in his quality as well as other parts of the life. It is easily diagnosable. It can be diagnosed by polysomnography in a sleep lab and in home monitoring, where you can do this, say, limited channel as well as polysomnography. And this is the typical or the least, say, invasive kind of a thing that I can show you. And that is basically, if you look at it, This is a normal, when the patient is awake, there is a normal parabolic curve. You can see the summation effect. The oxygen is fine. But the moment you go into sleep, there is snoring. These orange peaks are snoring and flattening of the curve, leading on to upper airway resistance. And the terminal event is stoppage with massive falls in oxygen saturation. So the treatment of choice is nasal CPAP, which is continuous positive airway pressure. Here, a flow generator basically gives an adequate amount of pressure so that these structures do not fall. In automatic one, it raises the pressure if there is a tendency to fall. So does not allow snoring, does not allow stoppages of breath, does not allow fall in oxygen saturation. Your basic metabolic rate, your metabolism is improving, and it helps in obesity, it helps in diabetes, it helps in hypertension. So it has to be looked into with some important thinking process. Now, this is something you can see a polysomnography where there are stoppages of breath leading on to fall in oxygen. The same patient with CPAP, no stoppages, no fall in oxygen saturation. There are surgical treatments which are there, but I think I will leave it to Dr. Seema for this kind of an activity. But generally surgeons are in a hurry, so don't be in a hurry because you need to know what patients should be treated on. Then there are dental appliances. I think somebody is talking about that also. So I will not meddle into that. But we developed the first, dental mandibular advancement splint around in 2001, 2002 with an orthodontist. And we are doing tailor-made kind of, appliances rather than ball and bite types. So there are a large number of pathways. The answer is to give them the right direction. Another important issue is myths about sleep disorders. Now, first is sleep is equal to rest, may not be equal to rest. That if one of the three limbs is not functioning correctly, even the full length sleep may not help you. Sleep medicine is not sleep apnea. Sleep medicine is not just insomnia. With 80s disorders, there could be influence of other disorders. So we must know what is happening. A lot of people feel that a glass of a wine or a beer will help sleep. The fact is that it can go into REM rebound, leading on to nightmares, and the person gets more addicted to alcohol. Myth is insomnia is characterized by only difficulty falling asleep. And as Dr. Ravi has told, there could be many ways of it. That is sleep initiation problem, sleep maintenance problem. So the thing is we have to look into it because we have different medication for all of these substances. They are not difficult to diagnose. They are rather easy. Very important myth is that I have learned not to need as much sleep. The fact is sleep needs are genetically determined and cannot be changed. Although the performance of the tasks can improve somewhat with effort, but optimal performance and consistency of performance do not. Another important myth is that I can tell how tired I am. I know when I'm not functioning up to par. But the fact is, studies show that sleepy people underestimate their level of sleepiness and overestimate their alertness. The sleepier you are, the less accurate your perception and degree of impairment, and you can fall asleep briefly, that is micro sleeps, without your knowledge. So there is actually this spooky side, but I'll leave this because of the time, being less. But it was interesting, so I just kept it. Then there is an economic impact of sleep deprivation. A severely sleep deprived person can go from wide awake to fast asleep in less than 10 seconds. As you can see over here, all that you need is a snooze on the wheel, and that can last for eternity. So it's very, very important that you feel rested after a sleep. And there was a big study, which was a multi-centric study, which was conducted in Adelaide, Manitoba in Canada, and in Professor Terry Young in Wisconsin. In Adelaide alone, there were 800,000 sleep apnea related motor vehicular collisions. The cost of the collisions was $16 billion, 1,400 important lives lost. The treatment would have costed just $3.8 billion. And there was a cool saving of around $11 billion and nearly 1,000 important lives. It has also been shown that treatment of OSA reversed the trend of increasing healthcare utilization seen prior to the diagnosis. So the fact that the direct health cost of sleep disorders was $146 billion, which was only 2%, that is around $7.5 billion of sleep disorders, is too little being spent on this treatment and reduce the huge tail of indirect impacts. So sleep is underrepresented and spread on the national level agendas, and despite the availability of good range of treatments. I think second is priority interventions should include public health education. Thus, in 2022, untreated sleep disorders and inadequate and unhealthy sleep remains one of the largest, deadliest, and most costly problems. Ignorance about sleep is the worst sleep disorder of them all, but there is a reason to it. Small number of practitioners, late start relative to the scientific and the clinical discipline. Teaching out sleep is almost totally absent from mainstream educational system. And last but not the least, people do not take their sleep seriously enough. So here's a man who changed our lives with artificial bulb, and we became a 24-hour animals, but there was no point to control the sleep better. So sleep is a human right, basic human right, recognized or not. Sleep is crucial to health, well-being, and social functioning. So we are a 24-hour cycle people today. What to do? Strategies for improving peak human performance must involve sensible awareness of human limits. Systems and procedures must be designed to play up to the human strengths rather than weaken them up. There is a persistent conflict between biological imperative for sleep and social demands for performance. This poses a fundamental question: what happens to the performance when the pressure for sleep is increasing? So sleep depth is basically like a lava which is ready to explode. As Professor William Dement said, that nearly half a century, a huge reservoir of knowledge about sleep, sleep deprivation, and sleep disorders has been building behind a dam of pervasive ignorance. We do not know how many preventable tragedies are occurring right now, today, this instant. It is time either to lower down the floodgates or blow up the dam. The challenge is that we must change the way society deals with sleep, and the opportunity is that the human race will be lifted to a new level of energy, health, and safety. And I'll just finish this presentation with the words of Sir Robert Frost. The woods are lovely, dark, and deep, and I have some promises to keep, and miles to go before I sleep, and miles to go before I sleep. Thank you, ladies and gentlemen.
Thank you so much, sir. It was very impressive presentation. Sir, we have I have two questions for this presentation.
Sure.
So, many people, they ask, is it unhealthy to sleep during daytime?
No, it basically unhealthy is, it's a reflection of your poor quality of sleep. If you need that much, it is not unhealthy, say per se, but because there are a lot of people who take siesta, a small kind of a sleep or a nap, that is not a problem. But if you are feeling sleepy and not rested, then it is a problem.
Sir, the second question is, do older people need less sleep compared to adults?
No, not really. But what happens is basically most of the people, elderly, especially those who have retired from the active jobs, they don't have a fixed kind of a regime for themselves. So they take their micro sleeps in the daytime. So in the night, they don't need that consolidated sleep, and they do not have that consolidated sleep. So it's not that their sleep requirement has gone down. They are sleeping at odd hours.
Thank you so much, sir. Thank you so much. Thank you.
Thank you.
Our third speaker today is Dr. Sapna Irashidaran. Ma'am is Additional Professor of Neurology at Sri Chitra Tirunal Institute for Medical Sciences and Technology at Trivandrum. Her areas of interest are stroke and sleep medicine, and she has more than 50 research articles and 4 book chapters to her credit. Ma'am will be talking on sleep and neurological disorder. And I now urge ma'am to enlighten us on this topic. Thank you, ma'am.
Good afternoon. Can you see my slide?
Yes, ma'am.
Good afternoon, everybody. I'm Dr. Sapna. I work in Department of Neurology, Sri Chitra Tirunal Institute, Trivandrum. And thank you, Dr. Nurul and team, for organizing this conference on the eve of the World Sleep Day celebrations. Being a neurologist, my topic is sleep in neurological disorders. So I will briefly talk about how important is sleep in brain health. I know that many of the speakers before me have spoken many of the aspects, but there will be some overlap. Please excuse this. And how sleep changes with health and normal aging. What happens to sleep in different neurological disorders with a focus on neurodegenerative disorders, cerebrovascular disorders, epilepsy, migraine, and immune-mediated disorders. And what is the role of sleep as a biomarker? And and I will conclude with my briefly about management of the sleep disorders in neurological settings. So coming to the importance of sleep and brain health, we all know that sleep is a universal need and a crucial aspect of overall health. The specific functions of sleep are still actively being researched, but the known functions of sleep include memory consolidation. We all know that much of our synapses are getting cooled, and long-term potentiation of the memory happens during stage 3 NREM sleep. Then there is a management of metabolic and cellular process which happen during sleep with the removal of toxic end products, and also energy conservation. In animals, it's equivalent to hibernation. So we also know that sleep quality decreases with age, and poor sleep is often a symptom of many of the age-related neurodegenerative disorders like Alzheimer's disease. So before going to the disease state, one should know what happens to sleep with changes in age. We know that sleep requirement changes with age. An average newborn sleeps for about 20 to 22 hours a day, and this gradually decreases to 10 to 11 years by 4 to 5 years of age, and 7 to 8 hours by adulthood. And as you all know, there are two stages, NREM and REM sleep. And the sleep is regulated by two processes which work independently and influences the sleep need. One is the circadian rhythm, which is mainly controlled by the external stimuli, that is a light, via suprachiasmatic nucleus in the hypothalamus. And the second is a homeostatic process. There is a sleep depth which gradually builds up as you remain awake. And once it reaches a critical threshold, there is an urge to sleep. So this is a diagrammatic representation of the sleep stages across the night. We know that in each night there is a sleep occurs in cycles of NREM stage 1, 2, 3, then REM, then again it cycles back to again NREM. So the sleep stages, when you compare the sleep stages in a child versus an adult and elderly, you see that there are a lot of differences. In children, the child spends a lot of time in stage 3 NREM sleep, which is a period when the memory consolidation happens. That is a slow wave sleep. The sleep is more or less continuous throughout the night, and towards the early morning hours, the REM becomes more dominant, and REM duration is almost stable throughout adulthood. In young adults, even though the duration of NREM stage 3 is slightly lower than children, the stage of REM is almost the same, and the sleep becomes fragmented, but very brief arousals, like 1 or 2 arousals every night may happen in the adulthood. But as the age increases, above 50 or 60 years of age, we know that the sleep becomes further fragmented because of many of the physical ailments as well as other psychological issues, and also age-related changes happening in the brain. So the duration of NREM stage 3, which is a slow wave sleep, which is very vital for memory consolidation, gradually decreases, and the duration of light sleep increases, which is a reason why often elderly complain that they hardly sleep in the night, or they quickly wake up when they hear a sound. So why these changes are very important? We know that in slow wave sleep, there is a clearance of cellular toxic metabolites, misfolded neural proteins like
Dr. Sapna, sincere apology for interrupting you in midway. There is some voices coming from background. Could you please check? Is any program is running in your system, or there is some very mild sound is coming from background actually?
Is it okay now?
Yeah, it's okay now. Thanks a lot.
Okay. Sorry about that.
Carry on. Okay.
The fan was making a lot of noise. Sorry about that. During slow wave sleep, as telling, there is a cellular clearance of misfolded neural proteins like alpha-synuclein, which is implicated in Parkinsonism, amyloid beta, tau, all of which are involved in major neurodegenerative disorders like Alzheimer's and Parkinson's disease. And also sleep deprivation also affects the glymphatic system. Glymphatic system is a glial-dependent metabolic waste clearing pathway and which works in the brain. Just like lymphatic system elsewhere in the body, the brain has its own pathway to remove the toxic metabolites called the glymphatic system. So in sleep, especially the slow wave sleep, the amyloid beta clearance is increased by 25 to 30%. Also, during sleep, there is an immunological and redox system getting downregulated. That is interleukin 6 levels, TNF alpha, C-reactive protein. All this get downregulated during sleep, especially in the slow wave sleep, thereby reducing neuroinflammation and oxidative stress. So sleep thus helps to maintain metabolic homeostasis through neural, humoral, as well as immunological support. So when this has been a puzzling question for scientists in sleep medicine. What came first, whether it was a sleep dysfunction leading to cognitive impairment or whether it was cognitive impairment leading to sleep deficits. So it's a classical egg and chicken question. In sleep deprivation, we know that there is an increased neuronal firing, excitotoxic damage, increase in amyloid beta secretion and defective amyloid clearance, leading to accumulation of beta amyloid and tau proteins, which can contribute to neurodegeneration. Whereas the reverse is also true. In Alzheimer's genetic disorders where there is a misfolding of protein and tau and excessive phosphorylation, this also can affect the sleep cycle and further worsen the cognitive dysfunction. So this is a bidirectional process. To understand the complex relationship and cognition, scientists have studied what happens to cognition in normally sleeping elderly, in patients with insomnia and people with sleep disordered breathing, which are the two common prototype sleep disorders that we see in day-to-day practice. So most of the studies have compared retrospective recall of habitual sleep duration with cognitive functions. And the studies have found that both short sleepers as well as long sleepers, that is if you sleep less than 5 hours a night and more than 9 hours a night, you are more prone to develop multiple cognitive dysfunction in multiple cognitive domains like memory and executive function. But polysomnogram assessed sleep and cognitive functioning have provided mixed results. Actigraphy, which measures sleep onset latency, efficiency, and all, have found that sleep dysfunction is also closely related to cognitive and executive performance. And what happens when sleep deprivation happens? Elderly show greater worsening of cognitive and executive performance than younger adults. And also, we know that learning, especially motor learning, is also optimized with good sleep in elderly. Community studies have shown that insomnia patients are at higher risk for developing sorry, I think my mic got muted in between. Continuing, insomnia patients, the elderly subjects who had chronic insomnia are more likely to develop cognitive dysfunction on long-term follow-up in community studies. However, therapy for insomnia, like cognitive behavioral therapy, has not been proven to be beneficial for improving cognition in this subgroup of individuals. And another common sleep disorder in elderly, sleep disordered breathing, has also been found to impair cognitive functions globally, more so in the domains of vigilance, executive function, and memory. And the long-term impact is earlier rates of mild cognitive impairment as well as dementia. I'm sorry, there's some problem with my slide. I'll just share once more. Sorry, the slide was not moving.
Dr. Sapna, you can share again. It will move. Okay. You share again. Try once.
Okay. Can you see the slide now?
Yeah, it's visible.
Okay. So the slide was not moving, that is why.
If it is not moving, you can, without going into the slideshow mode, you can just select and move on.
Okay.
You just select the slide and present.
Okay. I'll do that. Can you see the slide now?
Yes, ma'am. It's visible.
I think in the full screen, the slide is not moving. So I hope it is, you can read the slide.
Yes,
no?
Slide 11 number slide is now visible.
Yeah, okay. So long-term impact of sleep disordered breathing is that it can, untreated, it can lead to earlier rates of MCA and dementia. So this is a study from our center. We also studied the amnestic MCA group, whether the sleep architecture abnormalities can proceed or can one follow, whether it can increase the risk for developing Alzheimer's disease. So in this study, we looked into the polysomnographic variables of sleep onset latency, sleep duration, as well as the percentage of NREM sleep and REM sleep, and wake after sleep onset and sleep abnormalities in amnestic MCA patients as well as age-matched control people. We found that moderate to severe obstructive sleep apnea was more prevalent in amnestic MCA group as opposed to control group. And also the amnestic MCA group who had a better sleep efficiency and longer duration of REM had a better associative learning and free recall and memory performance. Higher AHI, that is severe OSA, had a negative correlation with visual memory scores. However, when these subgroup of patients were followed up for 3 years, we found that the progression to AD was not accelerated in the subgroup with the poorer sleep. So what happens in degenerative disorders like Alzheimer's to sleep? We know that the impairment sleep structure are markedly exaggerated in those with mild cognitive impairment and Alzheimer's in relative to age-matched cognitively normal adults. The analogous sleep impairment are also present in elderly who are at a higher risk for developing AD, like ApoE4 carrier mutation and E positives. Additionally, the decline in NREM sleep quality, especially the slow wave sleep quality, is accelerated in Alzheimer's patients with related to age-matched controls. The neurodegenerative misfolded proteins like amyloid beta and tau levels, which are measured in the CSF, predict the degree of slow reduction in slow wave sleep in Alzheimer's, and together with the decrease in sleep efficiency and NREM sleep. And both subjective and objective measures of poor sleep correlate with the severity of amyloid beta burden as well as tau levels. So this is a vicious cycle, and we can't exactly point to where the problem starts. So we know that MCI, minimal cognitive impairment, and Alzheimer's patients, they are more prone for sleep disruption, decrease in slow wave sleep, increased sleep fragmentation, and increase in sleep disorders. These itself can predispose to defective toxic misfolded proteins, defective increased production and decreased clearance of amyloid beta, increase in phosphorylated tau, and this can lead on to progression of degenerative disorders. Now, what happens to sleep in Parkinsonism? This is another major group of neurodegenerative disorders where some of the sleep symptoms can even act as a biomarker. The presence of sleep disorders is an independent risk factor for incident PD when compared to age-matched controls. The REM behavioral disorder is associated with a more severe motor as well as non-motor PD subtype. And this can precede the onset of neurodegenerative disorders like Parkinson's disease or multiple system atrophy by years. The CSF synuclein level in humans shows a diurnal variation and is increased during sleep deprivation. The pathological changes which occur in Parkinsonism, the synuclein pathology, it is found to affect key brainstem structures which are involved in sleep regulation. And these changes are also found in autopsy series in patients with idiopathic REM behavioral disorder also. So what happens to sleep with aging in healthy adults as compared to Parkinson's patient? In elderly, there is a slow progressive decrease in sleep efficiency, which is related to many of the physical impairments as well as age-related decrease in NREM duration and other sleep disorders. Whereas in Parkinson's, this gets accelerated due to coexistent other specific sleep disorders like REM behavioral disorders, coexistent depression, physical impairment due to rigidity, pain, etc. So the earliest stage pathology starts in the brainstem, the alpha-synucleinopathy, where patients can have non-motor symptoms like REM behavioral disorders, and other sleep dysfunction like fragmentation of sleep. Then gradually, as a pathology progresses to the forebrain, the symptoms, more motor symptoms and more cognitive issues develop, which is correlating with progressive worsening of sleep. In atypical Parkinsonism, there are a lot of sleep disorders which are commonly described. The prototype is REM behavioral disorder, which can precede or occur along with the onset of many of the neurodegenerative disorders like multiple system atrophy as well as Lewy body disease. Then nocturnal stridor as well as circadian rhythm dysfunction, which can occur in multiple system atrophy. Excessive daytime sleepiness, which is reported in many of the atypical Parkinsonian patients. Now coming to the next important neurological disorder where sleep is affected as well as sleep dysfunction can be even a cause, that is stroke. Some of the factors have been already mentioned by the previous speakers. I will just mention a few cardinal points related to neurology only. Sleep dysfunction is seen in more than 50% of stroke survivors, but very few percentage of them get screened for sleep problems because of lack of awareness among the physician, difficulty in doing a sleep study in a sick patient with disability, etc. The commonly studied ones in stroke are sleep disordered breathing and insomnia. The community-based studies have shown that the sleep disordered breathing and stroke have a close association. There is a 2.4-fold increase in the risk of vascular death or vascular event or death independent of presence of vascular comorbidities in patients with the OSA when compared to those without. Also, not only it can serve as a primary risk factor, there is an increased risk of recurrent stroke and poor functional outcome in patients with the OSA than without among stroke survivors. However, we know that CPAP therapy for OSA, the benefit on outcome and recurrence after the stroke still remains unproven. So this is a chart which I have taken from an article in Stroke recently in 2019. The many reasons are there behind low screening for sleep disorder, main being the limited access to testing as well as lack of awareness of the sleep disorders in this subgroup of patients. The common disorders being sleep disordered breathing and sleep-wake cycle disorders in stroke survivors. They both can increase the risk of incident stroke as well as recurrent stroke and can lead to poor outcome. Now, another major subgroup of disorders where sleep is closely related, epilepsy. This is a vast subject in itself, so I will be just going to some of the titles only. Sleep disruption of any kind, including sleep disorders, can worsen epileptic seizures and contribute to the burden of epilepsy. Several forms of epilepsy predominantly or exclusively manifest during sleep, and they tend to occur during light NREM stage. We know that the diagnostic interictal epileptiform discharges or IEDs or spike wave discharges are more likely to be activated during the NREM stage 3. Epileptiform discharges as well as anti-seizure medications can detrimentally impact sleep quality as well as duration. Also, sleep has an important key association with another sudden unexpected death in another entity called SUDEP, that is sudden unexpected death in epilepsy. So as I mentioned, there are some epilepsies which are predominantly occurring during sleep or can get activated in sleep. One subgroup being the nocturnal frontal lobe epilepsy or the sleep-related hypermotor epilepsy, then childhood benign Atlantic epilepsy, Landau-Kleffner syndrome, and some of the epileptic encephalopathies associated with continuous spike wave discharges in slow wave sleep. Often it is difficult to differentiate it from other primary sleep disorders like NREM, parasomnia, syndrome behavioral disorders, and may require a careful evaluation by a sleep specialist, often with the help of polysomnography. Then another entity which can occur in sleep, which often parents with small children complain of, they are afraid that their child is having any seizure, is a rhythmic movement disorder of sleep. Also, some of the sleep disorders are very common in epilepsy patients like sleep disordered breathing, RLS, and insomnia. Then another common neurological problem where sleep has a very close relation is the migraine and headache disorders. Often both coexist. Some studies support the evidence that migraineurs have worse sleep quality than non-migraineurs. Self-reported sleep quality is poor with associated increased frequency of attacks, and it can lead to chronification of migraine also. And preventive therapies for migraine often improve the quality of sleep as well. So, as I mentioned, sleep and insomnia and migraine has a bidirectional relation. We know that those with poor sleep have increased risk of developing chronic headaches, whereas migraine patients with chronic sleep deprivation, they can have a worsening of headache as well. Now, what is the relation between neuroimmunology and sleep? This is an area which is upcoming in neurology, and a lot of new antibodies and antibody-mediated disease are being described every year. Some sleep disorders are believed to have an immune basis like narcolepsy and Klein-Levin syndrome. We all know that H1N1 epidemic was associated with an increased number of narcolepsy in many populations. Some immune disorders have prominent sleep symptoms like Eglon-5 antibody disease, primary or secondary CNS demyelination, and many paraneoplastic brainstem and diencephalic syndromes. So this is a table I've adapted from Neuropsychopharmacology journal, which has come recently. Some of the immune-mediated or presumed immune-mediated neurological disorders with sleep symptoms. Many of the autoimmune mediated CNS disorders like anti-hematoencephalitis, LGI1, limbic encephalitis can have patients with the predominant symptoms like hypersomnia, secondary narcolepsy, REM behavioral disorders. Glon-5 antibody disease patients can present with cognitive decline, hypersomnia, sleep apnea, RBD. Then NMDA receptor encephalitis patients can have insomnia and central hypoventilation. Then before concluding the role of sleep as a biomarker, REM behavioral disorder is recognized as a prodrome of synucleinopathies. Synucleinopathies are a broad subgroup of disorders under which comes Parkinson's disease, multiple system atrophy, DLB, which is characterized by alpha-synuclein deposition in the brain tissue, and it can precede neurodegeneration by years. Idiopathic RBD patients on long-term follow-up, 15 years or more, has been found that over 80% converts themselves to one of the degenerative disorders like multiple system atrophy, Parkinson's, or DLB. Also, sleep fragmentation and reduction in slow-wave sleep. This can precede degenerative diseases like Alzheimer's and mild cognitive impairment, but the exact causative relationship is still not proven. Coming to the management, as we know, the management of the sleep problems is mainly management of the primary. Is a major symptom, management of primary disease like dementing illness or Parkinson's disease. If somebody has got poorly controlled Parkinson's disease with significant rigidity and tremor, then treatment of that motor symptom itself may improve the sleep disorders. Then another area where one can offer help is identify comorbid depression and anxiety as well as pain, which is very common in many of the neurodegenerative disorders. Then cognitive behavioral therapy has been found to have some role in management of insomnia in some of the neurodegenerative disorders, even though they may not improve the cognitive aspect. Then another troublesome symptom that many of the patients complain of is excessive daytime sleepiness. Often it can be secondary to medication side effects like levodopa, or it could be secondary to dopamine agonists. So if somebody is finding it difficult to tolerate medications, then reducing the dose or gradually hiking up the dose may help. Then management of coexisting OSA, and in some situations, even alerting agents like modafinil or armodafinil can be tried. Then another area which often patients seek the help of sleep specialists is in REM behavioral disorder. In REM behavioral disorder, we often give clonazepam or melatonin, but this is one subgroup of patients where the use of benzodiazepines has to be given with extreme caution because of their cognitive impairment, postural instability, and fall risk. If you use clonazepam, they are likely to have a fall and a fracture, which may make them bedbound. So careful, judicious use of medications only when it is strictly indicated. And there is some evidence favoring melatonin, which have less of after use side effects. So coming to the summary, sleep disorders are very common in neurological conditions. It can precede some of the neurodegenerative disorders like RBD. It can be associated with comorbid anxiety and depression, which also needs to be screened and managed. Careful evaluation of symptomatology and judicious use of investigations like polysomnography wherever indicated, especially if one is suspecting coexisting OSA or RBD. And also, while using medications, weigh always a risk versus benefit. That is, a risk of using a sedative like fall risk, excessive morning sedation, and cognitive side effects versus a benefit of therapy. Thank you very much for your patient listening.
Thank you so much, ma'am. Ma'am, I have two questions on this topic. Ma'am, do poor quality sleep can cause neuropathy in the long run?
The peripheral nervous system disorders and sleep dysfunction, it is not, there are no proven studies actually, whether sleep dysfunction can lead to peripheral nervous system disorders. But we know that peripheral nervous system disorders can lead to poor sleep quality because of the pain and other symptomatology. And that is one area where you can offer a lot of treatment to improve their symptoms as well as sleep quality.
So it is the other way around in medicine.
Yeah, it is the other way around.
Okay, ma'am. And the second question is, many times, like when we treat neurological condition, like for example, epilepsy and all, we prescribe anti-epileptic, and those medications, they cause excessive sedation in the patient, and that in turn leads to cognitive distortion, like for long run. Now, how can we counter this condition? Many times we see some physicians and neurologists or psychiatrists, they prescribe armodafinil in this case. So is it right to prescribe, or is there any other way to treat this condition?
Sleep and cognition is affected by anti-seizure medications in three ways. One is due to the drug itself, which can have a lot of sedative quality as well as cognitive. Then another factor which impairs your sleep is poorly controlled epilepsy per se. Epilepsy itself can produce a cognitive dysfunction, as well as it can worsen the sleep quality with the sleep fragmentation and sleep disordered breathing. So both has to be like the control of, on one hand, you have to control the epilepsy with a good dose of anti-epileptic medications. And on the other hand, you have to counter the adverse effects of the medication. So many of the newer anti-epileptics have less of cognitive side effects when compared to the first generation medications like phenobarbital. So that is one way to counter this. And other thing is rather than rather than adding an alerting agent, it is always better to use the medication at the least dose where the patient has maximum benefit as well as least amount of side effects.
Okay, so how justifiable is it to use armodafinil?
Armodafinil, I have also there. In epilepsy scenario, there is no recommendation for giving any of the alerting agents to counteract the side effects of the medication. What usually is advised is if the drug is difficult to tolerate, evaluate for any refractory causes of epilepsy, which has to be addressed. Otherwise, you bring down, if the patient is unable to tolerate that dose, bring down the medication or consider switching to because of the side effects.
Thank you so much. Thank you so much. Thank you. Now I hand over the moderation to Dr. Irfanul Haq. He is assistant professor in the Department of Orthodontics in Hazaribagh Dental College, Jharkhand. Over to Dr. Irfan.
Thank you so much. Our next speaker for today is Lieutenant Colonel Abhijit Cardoza. He is presently the Associate Professor of Orthodontics in Army Dental Corps. He is a classified specialist in orthodontics. He is the Associate Editor of Medical Journal of Armed Forces of India. He represented Indian Army in UN as a part of UN Peacekeeping Force in Lebanon. He is the topper in BDS in his university way back in 2002, and he has done his MDS from prestigious Armed Forces Medical College, Pune, and secured first rank in MUHS, Nasik. He has numerous publications in various national and international journals. He is the postgraduate teacher in the Delhi University, MUHS, Nasik, with special interest in dental sleep medicine, as well as in cleft orthodontics, surgical orthodontics, and craniofacial morphology and its correction to orthodontic problems. We welcome you, sir, on behalf of the National Health Academy, and it's really our pleasure to have you as our speaker. Over to you, Abhijit Cardoza.
Thank you very much for that wonderful introduction. Right now, I am stationed at Pune, and I would like to convey my sincere greetings from the armed forces and especially from the Army Dental Corps, which is supposed to be the largest organized dental healthcare setup in the world. Again, my gratitude to the National Health Academy for bringing all of us together and conducting such a wonderful program. Our armed forces has become synonymous with surgical strikes. So I feel this Nascon is also a surgical strike to make the civilians sleep well, but this time not with arms and ammunition, but with knowledge and knowing how we can sleep better physiologically. So thank you very much for that. As we all know from this whole conference that a new specialty is born, which is considered as the newest specialty as recognized by the American Medical Association, which is sleep medicine. and it was considered that the small part in that is played by dentistry, which is called as dental sleep medicine. But as evidence is coming in, this small part is becoming slowly larger and larger. There are n number of sleep disorders as they have been enumerated. But as a dentist, we are concerned with sleep disorders of the upper airway, especially of obstructive nature, like obstructive sleep apnea, snoring, upper airway resistance syndrome, or sleep bruxism. I will not go into the detail of the definitions because they have been already been told. The mute question is why a dentist has a pivotal role to play in sleep disordered breathing or obstructive sleep apnea. And why only human being is the only organism or animal who suffers with obstructive sleep apnea, that we need to know. And then we'll understand the importance of a dental specialist or a dental surgeon in managing obstructive sleep apnea. For that, let us just see what is the anatomic basis why human beings only suffer with obstructive sleep apnea. We developed from quadrupeds to bipeds, and we are paying the price for that. From Homo ramapithecus, Australopithecus to Homo sapiens to nowadays Homo macdonaldus, what has happened is we became bipeds. In that bargain, the vertebral column of the human being became straight. Foramina magnum migrated forward and brain size increased. Along with that, other change that predominantly happened was earlier our ancestor had a pout. That pout was gone and the splancocranium of the human face was tucked under the neurocranium in the modern human being. So the tongue, which was earlier the oral tongue, became oropharyngeal tongue. And you'll be surprised to know that this phenomena or this peculiarity of having an oropharyngeal tongue is there only in human beings. Other thing that happened with us was to develop intelligible speech, which is called as the great laryngeal descent. At around 1 year of life, we have the larynx which descend downwards, and we develop a portion called as oropharynx. This oropharynx is an entity which is peculiarly present in human beings. In all other animals, the soft palate is directly in contact with the epiglottis. But in human beings, we have a portion called as oropharynx, where the tongue from oral tongue became the oropharyngeal tongue. So 3-4 things happened together. One, foramina magnum migrated forward. The vertebral column became erect. We had clinorhynchi, that is the pout was gone and the cranium was stuck inside. We had the oropharyngeal tongue and the larynx descent downward. This all ended into compromising the vital human airway, and that is why human being is the only organism or animal who suffers with obstructive sleep apnea. So if you see the phenotypes of obstructive sleep apnea, there are 4. First is upper airway anatomy issues. Second can be poor ability of the upper airway dilator muscles to respond to pharyngeal collapse during sleep. Third can be increased propensity to wake up from respiratory stimulus during sleep. And fourth is what we call the loop gain. Out of these 4, if we see 80% of the subjects who are suffering with obstructive sleep apnea are because of some kind of anatomical impairment, and the others being a minor cause. So as per research, central apnea is about 0.4% and obstructive is about 84% and mixed amounting to 15.6. So if you see 99% of the obstructive sleep apnea is because of some kind of obstruction. And where does this obstruction occurs? Because of certain skeletal causes like retroposition mandible, hypoplastic mandible, lower position hyoid, or retroposition maxilla, or a hypoplastic maxilla. Or can be because of soft tissue causes like larger soft palate, smaller pharynx, or larger tongue. Or it can be because of miscellaneous causes like hypertrophied adenoids, enlarged tonsils, deviated nasal septums, or certain kind of pharyngeal masses. If you see all these area, they come into the jurisdiction of dentistry. So that is why I said dental clinicians or dental surgeons have a pivotal role to play in cases of obstructive sleep apnea. So this new specialty of dental sleep medicine encompasses evaluation of craniofacial risk factors, oral appliance therapy, as we will see in further, maxillomandibular advancement surgeries to actually obviate the obstruction, We can analyze the cases using cephalometry. And the most important thing that a dentist or orthodontist can do is prevention of sleep disordered breathing in children with RME, maxillomandibular growth modification, or orthodontic treatment. And this capability of the dentist is not till known to the medical fraternity, which has to be embossed and emphasized time and again. And the dentistry should come into mainstream in management of sleep disordered breathing. So diagnosis, we know that the gold standard is polysomnography, which gives AI, AHI, HI, RERA, RDI, and things like that. But the important thing that the dentist can see, and we can identify sleep disordered breathing at a very early age, or when the patient walks to you, are the signs of mouth breathing. Mouth breathing is an ongoing pattern, may be a sign of impending sleep apnea. And the facial features can be lip incompetency, puckering of chin, adenotonsillitis, airway grading of Malampatti more than 3, allergic shiners, enlarged uvula, severe clockwise rotation of the mandible, what we call the long faces, small nares, and high or narrow nose, and enlarged or crenulated tongue. So all these things a dentist can easily identify and refer such patient to the sleep physician or a pulmonologist. So in today's day, open mouth posture is the most common and significant soft tissue dysfunction in children today. If as a dentist we can identify them and refer them and treat them, then we have one half of the war. This is a wonderful indication or a picture which has been published in a study by a Danish group, where they say how the profiles are being graded for suffering or having a possibility of developing sleep apnea or sleep disordered breathing, is the right side being the most prone to develop sleep disordered breathing, and the left side one can be the least prone to suffer with sleep disordered breathing. So if you can identify a case easily in a clinic that a profile is like this, and this profile is more prone for developing sleep disordered breathing, and refer them subsequently to a suitable specialist, then it will be a great help to managing cases of sleep disordered breathing. We have various imaging modalities: fluoroscopy, nasopharyngoscopy, which can be done by an ENT surgeon. We have cephalometry, we can assess on CT or MR imaging, and nowadays we use acoustic reflection test. If you see this MRI here, you can easily say that the airway is compromised in a case of mandibular hypoplasia. We in our own centers have developed a cephalometric evaluation criteria for the upper airway, which is an 11-point criteria, which exactly measures the nasopharyngeal airway space, superior airway space, posterior airway space, evaluate the hyoid positioning, hyoid distance, how the hyoid is placed vertically, how is the length of the soft palate, what is the thickness of the soft palate against the norms, so that we can easily evaluate the airway on the lateral cephalogram. And this immensely helps in managing and treating the cases with sleep disordered breathing. Lateral cephalogram, which is a tool which is available in dentistry or with the orthodontist, not only tell you the dimensions, but nearby visually seeing it, we can say that in this case of Crouzon syndrome, the upper airway is completely obliterated. So we can say that this girl is liable to suffer with obstructive sleep apnea. Here in this case, we can see that there are enlarged tonsils, and these enlarged tonsils can be seen on the lateral cephalogram. These are the enlarged adenoids. So easily seeing the lateral cephalogram, we can say that this person is having some kind of airway compromise and is liable to suffer with obstructive sleep apnea. Other important test that we are doing in our centers right now is acoustic pharyngometry. In acoustic pharyngometry, we use the sonar technology to exactly know where the airway is compromised or where there is narrowing of the airway, right from the nasal tip to the hypopharynx. So by this way, we can easily know which area is to be treated. There are various treatment modalities, the gold standard being continuous positive airway pressure, but surgical procedures are the only procedures which can in toto treat the obstruction and can obviate the obstructive sleep apnea or sleep disordered breathing. There are various appliances that a dentist can give, and most important thing that is neglected is prevention of sleep disordered breathing using growth modification. and I will be showing certain cases that will emphasize this point. So treatment, we say that it is successful when we get 50% of decrease in AHI or RDI. So if you see the definition of orthodontics, the definition says it all. Orthodontics includes the study of growth and development of the jaws and face particularly, and the body generally, as influencing the position of the teeth and the jaws. And if you can influence the position of the jaws and teeth, you can easily obviate the problems which are occurring because of obstruction in the airway or problems of sleep disordered breathing, and that correction can be done. The craniofacial development, which is a very important attribute in having anatomical problems in sleep disordered breathing, it happens largest increase within the first 4 years of life, and 90% is completed by 12 years of age. So as a dentist, as an orthodontist, if I can identify a case who is having craniofacial risk factors, and I can for whom I can modulate the growth, then I will be able to prevent and treat obstructive sleep apnea and sleep disordered breathing, and it has to be started early in the life. So it is said that tongue is the scaffold for the upper jaw, and when the tongue rests on the roof of the mouth and teeth erupt around the tongue, forming normal shape and will allow to form normal shape and size of the jaw. Finding room for all the teeth is not a common problem if we start early and mimic what the nature has intended. So if we can guide the position of the tongue and modulate the growth of the upper jaw, we can obviate the problems which are going to come in future life. There are studies which indicate that rapid maxillary expansion and adenotonsillectomy is the first line of treatment in obstructive sleep apnea in children. Here is a case of narrow maxillary arches. Here we can see that the lower anterior facial height is increased and she has slightly longish face. When we saw the lateral cephalogram, you can see here she has enlarged adenoids which are completely blocking the airway. And when we did the polysomnography, her AHI was 33.5. So she was a severe case of obstructive sleep apnea. We undertook the adenotonsillectomy and then rapid maxillary expansion using a bonded Hyrax appliance. Here we have expanded the jaw. This is the jaw when it was completely expanded. You can see how well formed it is. At the same time, the mandibular hypoplasia, it got corrected because this allowed the lower jaw to grow forward, and we can see that the convex profile has become almost straight. Herein you can see not only we have aesthetically improved the patient, but the hyoid distance, which was around 30 millimeters earlier, has changed now to 15 millimeters, and the airway has opened like highway. Most importantly, the polysomnography report, which earlier read 33.5, is now reading only 5. So this girl was not only aesthetically helped, but her functions were also improved. There is an entity called as functional appliances, and these functional appliances, the appliances which actually modulate the growth of the upper and lower jaw. And it has been seen that the RCTs have shown that there are studies which suggest that with functional appliances we can actually obviate the obstruction in the airway and can help these cases to be functionally performing better. Here is a case, a 12-year-old girl who came actually for forwardly placed upper front teeth, but when we took history, we realized that she is suffering with obstructive sleep apnea. Here we can see that she has narrow maxillary arch and hypoplastic mandible, overjet being around 10 millimeters. When we did the polysomnography, her AHI was 21.3. Again, in children, this lands into a severe obstructive sleep apnea problem. Her posterior airway space was around 5 millimeters and higher distance was 18 millimeters. We gave an appliance called as twin block, which helps in optimizing and modulating growth of mandible and allows the mandible to grow as nature has intended. This is after completing the functional appliance phase. You can see that her profile has improved, the jaw size has increased, the mandible, which was earlier 10 millimeters back, has come to optimum position. Not only that, the posterior airway space was improved. higher distance reduced, and AHI importantly reduced from 21.3 to 6. The other thing that dentist can do are the oral appliances, as been told by many other presenters also earlier. These were actually given in early 90s to obviate the asphyxia in Pierre-Robin syndrome. Till 1950s, we thought that they only stimulate growth of mandible, not recognizing them for airway improvement. In 1970s, their impact on airway was investigated. In 1982, Charles Samuelson, which was a psychiatrist, used for the first time a tongue retaining device for his own breathing issues, and from where it all started. In 1990s, we used separate maxillary and mandibular component oral appliances. In 1995, American Association of Sleep Medicine proposed practice protocols which were modified in 2006 and 2015. And in 2014, we had consensus and evidence-based INOSA guidelines by Government of India for managing obstructive sleep apnea with oral appliances. There are various types of oral appliances, basically classified into tongue retaining devices and mandibular advancement devices. Mandibular advancement devices can be monoblocks or separate maxillary and mandibular component appliances, which allow for the freedom of movement of the lower jaw. They can be titratable or non-titratable. The tongue retaining devices are nowadays not that frequently used because it is very difficult to work with these appliances. These are certain examples. Like these are most commonly used a tap screw or a MDSA appliance in dental surgery. There are around 90 appliances which are available over the counter, but the customized appliances are better for results. They work on a simple philosophy. They prevent collapse of the upper airway and maintain patency by providing stretch to the pharyngeal musculature by either advancing or opening the mandible or holding the tongue in advanced position. Their mechanism of action is elevates the base of the tongue, tenses the palatoglossus muscle and pulls the soft palate forward. They decompress the tissue around the pharynx and allows the pharynx to expand. They help to stabilize the lateral pharyngeal wall by applying tension to pterygomandibular raphe and place the tonsillar arches formed by palatoglossus and palatopharyngeal muscles, which leads to further stabilization of the lateral pharyngeal wall. Indications as by ASM are mild to moderate OSA who prefer this treatment as opposed to CPAP. Now, as the evidence is less, indications are also limited. They are given in patients with severe sleep apnea who are unable to tolerate CPAP or who have failed surgeries, or we can easily give them in benign snorers. As I said, if we create evidence, then these indications will increase. The current evidence says that mandibular advancement devices have shown significantly improved objective sleep measurements like AHI, arousal index, snoring, and arterial oxygenation. They significantly improve subjective and objective measurements of sleepiness, quality of life, and blood pressure. CPAP and MAD have similar improvements in cardiovascular outcomes and inflammatory markers as per the Cochrane database. Here is a simple case. Here's a case of obstructive sleep apnea, skeletally absolutely normal, had a posterior airway space of 6 millimeters, AHI of 18.3. I just gave a mandibular advancement splint and he was helped. His AHI reduced from 18.3 to 0.7. Other important thing that and only curative thing that we can do are maxillomandibular advancement surgeries, which can be maxillary advancement with the help of orthognathic surgery or distraction osteogenesis, mandibular advancement by orthognathic surgery or distraction osteogenesis, or can be maxillomandibular advancement, genial advancement, or surgically assisted rapid palatal or mandibular expansion. Here is a case: a 12-year-old girl was referred from Department of Pulmonology for her airway issues. A case of unilateral mandibular ankylosis with AHI of 57.3. Here you can see that her mandible is deviated towards the side of ankylosis, that is the left side. You can appreciate the mandibular hypoplasia, collapsed upper arch. She was not able to open her mouth at all. Here we can see that the ramus was completely fused with the temporal bone, which we called as Sahni's class 3 mandibular ankylosis of the temporomandibular joint. We taken her up for osteoarthrectomy and interpositional gap orthoplasty. Her mouth opening was ascertained first. This is post-arthrectomy. We could have 25 millimeters of mouth opening. Here you can say that the collapsed arches are there. This is before the surgery, pre-surgical photographs. We decided to treat this case with mandibular advancement with the distraction osteogenesis. Here we can see that her posterior airway space is absolutely narrow. This is on a CBCT where we can see that the airway space is narrowed. Vector was planned parallel to the mandibular, parallel to the occlusal plane. Here we place the distractors and did asymmetric extraction because she had an asymmetric face because of unilateral temporomandibular joint ankylosis. We distracted for around 15 days and then did the callus molding. You can see that there is some semblance of occlusion now. Here is before removal of distractors. We can see a good bone is formed. This is settling. Now see, her face is completely changed. Not only face, she is now a grown-up lady with a beautiful smile and profile, good functional occlusion. Not only that, airway is improved, which is seen on the CBCT also, and her AHI from 57.3 reduced to 17.7. So this is a comparison where we have almost changed her life. So in spite of this mounting evidence that procedures like functional jaw orthopedics and rapid maxillary expansion and surgical mandibular and maxillary advancement can enhance nasopharyngeal airway, it does not find a mention in the goals in most of the standard textbook. This is not only my opinion, but the Time magazine also has a cover page or a issue which is devoted to sleep, and it also says that dentists are not utilizing their potential for managing sleep disordered breathing or sleep related issues, which can only happen if we have a evidence-based practice, which will happen only when we have research regarding prevention of sleep disorder breathing, evaluation of craniofacial risk factor, how to diagnose inflammatory markers in the dental condition, effect of various treatment modalities, oral appliances, and comparison of oral appliances with the gold standard. So I see a dentist in 21st century being based on adaptation, muscle focused, aesthetic secondary, treating causes, and airway conscious. By that way, we have increased stature and better integration of dental profession in the healthcare system, and we will have a system of referrals from ENT specialist and from pulmonologist to a dentist for management of cases which are related to sleep disorder breathing. So the time has come to go back and rethink the strategies. We have to look into evolution and adaptation and muscle function more diligently. So intelligence is the ability to adapt to change as per Stephen Hawking, and the time has come to adapt to this change and integrate dentistry into mainstream practice of sleep medicine. As per the father of facial development, who says that from the first day of all throughout life, the jaws help maintain the vital human airway, are the words by the great Enloe. And who are the guardians of this jaw? The guardians of the jaw are dentists, and I find their role more pronounced in management of cases of sleep disorder breathing. Thank you, and Jai Hind.
Thank you so much, Abhijit Kadu sir, for such a nice, informative and enriching session. Of course, as you said, that dentists play a major role in the early detection as well as correction especially by growth modification. But sir, one question to you, sir. In the BDS curriculum, there is we don't teach much about the OSA and all those things. Being an orthodontist, of course, we are exposed to this subject. But BDS, it should be included in the BDS curriculum as well.
Yes, so absolutely right. This is not the problem with BDS curriculum only, but if you see, the management of sleep and sleep disorder breathing is very less taught in MBBS also. So we need to awake to this fact that sleep is a very important attribute of life, and sleep related problems are one of the major concern of healthcare nowadays.
Yes, sir. Thank you so much, sir, for sparing time with us, and it was really nice hearing you, and hopefully I'll be in contact with you in future as well, sir.
Thank you very much.
Now I'll hand over the moderation to Dr. Sadia Islam, who is an assistant professor in ENT in Jawaharlal Nehru Medical College and Hospital, AMU Aligarh. Over to you, Dr. Sadia.
Thank you, Dr. Irfan. So it seems that for today's webinar, I've been given a task which is the most difficult one, because I have to introduce a person who actually needs no introduction. So I'll be introducing Dr. Mark Shaikh. He is an ENT surgeon with experience of more than 25 years. He is currently based in Pune and is HOD ENT at Inamdar Multispeciality Hospital. He is also consultant ENT surgeon and sleep specialist at KM and Sayadri Hospitals in Pune. He is the founder, national president of Indian Association of Surgeons for Sleep Apnea. He is considered the pioneer in India for spread of awareness of snoring and sleep apnea issues. And it is his artwork actually that has brought this field of ENT to where it is today. An internationally acclaimed speaker, a brilliant surgeon, a keen academician and a teacher, and a very humble person. I think we are very privileged to have him for today's lecture, and there could be no one better than him to apprise us on the role of ENT surgeons in sleep disorders. Over to you, sir.
Thank you, Sadia. Thank you very much for those words coming from one of the people whom I have seen evolve and grow in ENT. That feels nice. I hope the audio is good, because I was watching a few things and I did not see the audio coming in very clearly. So can you just let me know if the audio is good enough?
Yes, sir.
Yes, sir, it is.
Okay, great. So without much, I'm going to start off with sharing my screen. And there it is for you all. I hope you can see it. I'm trying to get it full screen. Right. So at the outset, my disclaimers, I am not here to kind of talk about any competition between the other fields that have been speaking versus the surgical management. And I have always right from the beginning, acknowledged that OSA is a teamwork and needs a very, very strict multidisciplinary approach. So based on that, this is what I'm going to talk to you about today, about how it has kind of evolved in the past few years. Sorry. So to take a few steps back, what Dr. Abhijit just mentioned and what Dr. Irfan asked him about the curriculum in the MBBS and in dentistry. So sadly, Dr. Abhijit, you must also realize that the ENT curriculum also did not have a chapter in the Scott Brown for OSA when I graduated way back, about 26 years back, 30 years back, 1991. So it's really a very recent one, and that's why so much has to be done by all of us in different fields. Recent editions of Scott Brown at least have got a chapter on OSA. And that's happened because we've been trying for the past almost 15, 16 years to get an understanding of this entire thing. So a lot of speakers have come across and spoken about their respective specialties. And I always believe that I want to keep this very short, very precise, very clear cut to just try to give you all an understanding. Because, you know, I heard a statement by Dr. Abhijit, which struck me while he was talking. And he said that the surgical management of the obstruction is the final actual treatment for obstructive sleep apnea. And that's the fact, because it's obstructive sleep apnea. And unless you get rid of the obstruction, you're not really going to get too far away. Now, my talk is restricted to OSA, although this is a program based on World Sleep Day where a lot of specialists have spoken about different sleep orders. And we will have a panel after this moderated by Sadia for all of us. But I'm going to be very precise here with regards to how the role of an ENT surgeon has evolved. I'm not talking about what the role is, how beautifully it has evolved over the years. Because many years back, we were not taking the right kind of interest in the field. As one of the slides put up by Dr. Manchanda was that every surgeon was very knife happy and you would just go ahead and start cutting what you get. And we were not really looking into the physiological aspects of the disorder back then, you know, and that's why times have changed now. We want to take into consideration everything. And I will start by obviously acknowledging that today, evidence-based science still says that CPAPs and BiPAPs are the gold standard for treatment. Now, again, I will make a small additional statement to that, saying that for want of better evidence today, we are still going by that statement. When we totally acknowledge that and accept that, right? Because what the surgeons did many years back was just this. They used to just chop away the palate. That would reduce the snoring, and everybody thought that was the end of it all. And then when evidence-based medicine started looking at it, you realize that the success rates were bad. They didn't last very long. There were lots of comorbidity issues. You had velopharyngeal insufficiencies, and worst part was that the PAP therapy after that was not really helping out. So people did realize that. So if you take a look at the development of CPAP from say 1963, when Professor Christian got CPAP brought into the system, and the first surgeries of UP3 done by the Japanese people way back again in 65, 68 times. And if you take the journey from then to now, and I'm talking pre-pandemic only till 2019, if you see the improvements in what has happened within both the segments, CPAPs also have come way and leaps and bounds ahead with their technology, and so has surgery in very, very many ways. So let's try and understand this part of it, because I was very instrumental and I was very strongly advocating that a surgeon's evaluation protocol should always have a PAP trial with it, which earlier surgeons did probably not believe in, because like Dr. Manchanda did mention, knife happy. But look at it this way. My argument was, if I find an obstruction there, if I know the patient has neurocognitive symptoms or patient is not doing too well, if I have some indication of finding out whether the improvement in oxygen supply reverses the entire situation, then only it logically makes sense in me trying to find out the obstruction and treat it, right? That's the basic understanding that we have to have. And that's why in your evaluation, before you get into any invasive situation with the patient, a PAP trial becomes very mandatory so that you are able to understand what is the reversal of the symptomatology that the patient has come to you with. What else has changed? We were earlier very, very broad in classifying the levels of obstruction. We used to just say, oh, retropalatal, retrolingual, hypopharyngeal. This was like a very broad situation. That's changed now. Now we talk very specific sites. We talk about very, very specific sites about where is the level of obstruction. We've got flexible scopes. We have dynamic MRIs. We have drug-induced sleep endoscopies. I'm not going to get into nitty-gritty of any one of these. I'm just going to try and give you an understanding how it's become so specific. We don't say it broadly. We look inside. We look inside endoscopically, which gives us an intrinsic view. And we look from the outside with either the MRI or the physical evaluation that gives us an extrinsic view. So we have a complete picture of the airway then in the vertical plane as well as in the axial plane at different levels. So we know exactly where the obstruction is going to be. Now, when I used to present this at non-ENT forums, I was bombarded with a whole lot of arguments saying, Dr. Saab, you're doing this, you're fine, you're looking at the level of obstruction, but you have no idea at what stage of sleep is that happening. So as you go into deep sleep, the obstruction levels change. So this was the scientific argument. This was the academic arguments. So I went ahead and started doing what we could do the next best thing. We started doing an intra-procedural PSG. So here I am doing a DICE where I'm seeing the level of obstruction there on the monitor. But I have a simultaneous PSG attached to the patient. So depending on where the apneas come in and what stage of sleep I'm actually seeing that patient in, that's where I'm actually noting down the level of obstruction. So this gave me more objectivity to figure out that, okay, this is the level of obstruction that I'm dealing with at a time when the patient is really in this stage of sleep. This is how we try to evolve ourselves, and we started reporting it in a very different manner. We started getting the third area of collapse. So we were not just talking about 2 planes of collapse. We were talking about all 3 planes of collapse completely. And we developed a system where we started kind of reporting this in this format. So it's become more specific. So just to give an idea to people, all of us in our MBBS curriculum or even those dealing with the cancers do understand about the TNM classification. You have the tumor nodes and the metastasis classification. So when 2 onco surgeons or onco physicians are discussing T1, N2, M0 or T2, N2, M1, they know exactly what they're dealing with. Same way, we started talking in terms of V2C, O2L, T2, E2, AP, which was like at the velum, you have a complete collapse of the concentric variety. At the oropharyngeal level, you have a complete collapse, but only on the lateral side, etc., etc. So this gave us a better picture to understand somebody sitting in a different corner of the world talking to me about something that they saw in DICE, and we can try and figure it out exactly as to how that helps. Okay, so again, technical glitch. I'm going to stop sharing and restart sharing again. Right. So that helps us try to figure out exactly at what level we are going to do what, not getting into that again. Then we had dynamic MRI. So this is what I told you about the imaging. Now, if you see in this, I know exactly at vertical level where exactly the obstruction is coming. And if I do the same thing in an axial plane, I have an anteroposterior as well as a mediolateral diameter here, which is measurable at exactly the same level, actually. So this makes my procedures more evidence-based at the end of anything that I do, where I can compare them exactly at that same site. So if I've done like a radiofrequency tongue base, or if I've done like a radiofrequency palate, I can compare it exactly with measurements as to what kind of results I have achieved. We also have post-procedure assessments of actual air volumetric assessment. So this again tells me exactly how much I've been able to increase that area by, right? So that's how assessment becomes more evidence-based. It wasn't like before where we would use a general statement and say, oh, my patient improved, my patient is doing well. Because however I do at any platform on the world, if I have to stand up and speak, they don't really care who Dr. Mark Shaikh is. They say, you may be anybody. Please give us data. Please show us the figures, show us the facts, and then that you talk. You don't talk that, oh, my patient improved. So these are the results that we managed to get after a few months of treatment. This is not just immediate post-op. This is a few months. We've got equipment now which is so bloodless. So this is coblations around. Everybody understand that. We can do kids who are as old as just 2 years old and remove their obstruction bloodlessly, which helps in preventing pediatric OSA from turning into adult OSA. But this is something that we can do now with the advent of technology. The arguments that I was always put up with was the fact that it's very unsafe to do nasal surgeries and palatal surgeries together, right? We've got such lovely stuff now. So I do a nasal surgery and a palatal surgery in a patient, and the patient is absolutely safe post-op the way we kind of do it now, and we pack it up. So when I have a nasopharyngeal airway and I've packed both sides, I still have a very fantastic patient post-operatively who I am not worried about the airway. So the morbidity that we were worried about once upon a time also decreases now. And we have it evidence-based. So we know now, and this is, I think, nothing new that I'm going to tell most of the people in the field of sleep medicine, that the nasal surgeries become extremely important because that's the main entry of the airway. And even if, let's say, it does not really improve the OSA in a great manner, it definitely helps reduces the CPAP pressures and makes the compliance of the CPAP much better. So whichever way you look at it, nasal surgeries definitely are hugely beneficial in patients with sleep apnea. And this is a position statement in the American Association also, way back in 2000, where they clearly put it down as a position paper and said, nasal surgery can facilitate the treatment of OSA, not just by opening up the airway, but also by opening up the compliance to the CPAPs. Now, we didn't only stay back at the nose. We also went forward with the throat, where things were very different. So if you see technology today, we have very safe procedures where we are just opening up the airway in the throat. There's no blood. There is no danger as such. The tonsil fully removed was not really required. We have got into the concepts of tonsillotomy. Thereby, pediatricians were also more appreciative of this process because they thought that the immune system would otherwise not be working. So we've got this in our armamentarium. The biggest controversies were in the palates. So palate surgeries have come a long way. Not just the somnoplasties that are done like this, which gave you the, but UP3 we've now kind of discarded as obsolete. We realized that everything was based on a muscle of the lateral pharyngeal wall, which we were not looking at. And this was the palatopharyngeus muscle, which needed to be expanded laterally. So I'm going to give you a pictorial depiction. So earlier what we did was we just pulled it up here to the palate and saw the expansion, realized that probably this was not good enough. So we picked it up again and went a little bit more laterally to the pterygoid hamulus, realized, okay, this is also good, but still not good enough. Then we took it to the lateralmost part in the oral cavity, which is the pterygomandibular raphe. And when you do it on both sides, on this side and this side, you can imagine the lateral airway opening on this side, as well as an anterolateral opening on this side. So the airway opened up three-dimensionally. And we evolved from here, we went to the lateral side, we went to the lateralmost side. And then we realized that we had so many procedures, it would get confusing. Which of the ones are we supposed to use? So again, the whole process of choosing becomes very methodical. And this is what I like to call as the double S algorithm. It's the Mark Shaikh algorithm. Hopefully I have to get this published. I'm not going to get into details for the non-ENT people, but this clearly lays out the pathway in which when you look at the algorithm, when you look at the palate, you can figure out exactly what kind of surgery you need to do. And that surgery becomes evidence-based. Like I told you, you look at the obstructions and you see the evidence base at the end of it. So we progressed from the nose to the palate to the pharynx and then down to the tongue base. So much has improved with the tongue base. We've got such a huge armamentarium of procedures that we are dealing with the tongue base here. And I'm not going to go into it nor play the videos, but I'm going to show you the results. Look at these results. These are published results. Results of improving the airway in the range of 39% to 78%. That's a wide gap, but that obviously is because it's a longer period of longer period of study, and the criteria used were very different in different assessments. So all in all, there is a great amount of success in the surgical interventions. But let me also try to give you a very broad surgical candidacy. So when you have a hammer in your hand, every nail looks to be just hammered. But that's not the case. So exactly like what was said earlier, surgeons don't need to be very knife happy. You got to have very clear-cut surgical candidacies. And we start off with the first one. Like I acknowledge the fact that PAP therapy is the most important one. We also have to realize that if there's a failure of PAP therapy, then that's when you have to come in and try to do something to improve that patient. So failure of CPAP compliance, type 1 obstructions, moderate RDIs, but with a lot of daytime somnolence, and most importantly, anywhere where there's an identifiable site of obstruction. Whenever you have an identifiable site of obstruction, that's the one that really needs to be brought in. And you always have to do this with a defined failure, not just with anybody. So like Dr. Manchanda had mentioned, and I do identify with him totally when he used to say that trigger happy surgeons, knife happy surgeons. So you do not do that. You should never do that. You should wait, try out everything, and then take a call. But at the same time, as a surgeon, there are certain categories of patients whom I would never touch. I would never touch. Just because I have the knife in hand. No, a morbid obese patient is not meant to be operated. Patients with low motivation issues, definitely not meant to be operated. So I try to teach most of my students also whenever I talk. I use the word, the patient has to earn his surgery from me. It's not that I have a patient who's willing to get operated and I will operate. No, the patient has to show me that he's motivated enough, he's willing to lose a bit of the weight loss that he has. Only then am I going to touch him. Because if I land up touching a non-motivated patient or somebody who doesn't have any physical activity or who's got tremendous comorbidities where the risk to benefit ratio does not match, then I'm going to land up in trouble. And that's not going to be a successful result at all. So that's something that I will never do. And the other thing that we have to realize is the concepts have changed. We now So why did UP3 come into the blacklisting also? Because it was just a single procedure. A single procedure was given and that was it. And then that didn't work because people didn't realize that it ended not at the palate, but there was much more below, retropharyngeal, hypopharyngeal. And if you identified those, and if you staged your procedure, and if I told that patient, I'm going to do your palate, and then I'm going to do your tongue base maybe 2 months later, and then maybe attend to your epiglottis 2 months later, then statistically that does not become a failure because it's a staged therapy that we're doing. So it's very important for us to get it across to the patients that there is no single shot, one shot cure in a surgical management. And you've got to earn your surgery by wanting to show your evaluation. Let me play you a little funny video just to give you an understanding of why things are changing with the surgeons. So if you can hear this video.
Ye hai NASA's most ambitious project ever, Juno, the spacecraft on a 5-year mission to discover Jupiter's secrets. Juno's scientific payload includes a color camera that will give the world the first ultra-wavelength microwave radiometer. In addition, it also has specially designed no cameras, please, ultra-high-speed engines that will take it to Jupiter in just 1 year. Any questions? Yes. Kitna deti hai?
For a country obsessed with mileage.
So that was the problem. So do whatever I may. At the end of it, what was the question that I was asked? Have you achieved an AHI less than 10? Have you brought down the AHI less to 50% and preoperative? That's where I think if I can make even a slight change in mindset. So what are we looking at when we talk of success? Are we just treating that AHI? Are we just looking at the oxygen levels? Or are we overall looking at the improvement in the quality of life quotient? Are we looking at the improvement in CPAP compliance? Are we not looking at the bringing down of pressures needed, thereby making the patient's life much easier? So let me try to depict this pictorially to you. This is what we want. We want to have cure. We want to have significant improvement and failure. And a patient comes to me at this stage. So he's got snoring out here. He's got RDI there, nocturia, BP, EDS, whatever. And I do whatever I do after I've thoroughly evaluated him and I've decided, okay, this procedure has to be done. This has to be done, whatever. And post procedures, this is where the patient comes in. Now, obviously, he is not at the cure in every parameter that we've looked at. But isn't this better than before? Doesn't this make his quality of life way better than before? So that's where we're trying to kind of bring in a concept of a sleep goal criteria, which will encompass everything. It will encompass all the things, the Epworth sleepiness scale, the pressures, the weight, the oxygenation, the AHI, the quality of life issue. And then we would be able to get a better idea about whether the procedures have been successful or not. So it is important to understand that when you bring in multiple criteria, it's not so simple like, okay, AHI was this, now AHI is this, and whether it's a pass or a fail. There is a gray area. So we are going to be probably making this a little bit more complicated by bringing in multiple indices to be assessed. But overall, it would probably be more holistic and more comprehensive than using one single criteria is what we presume. But having said all this, I must bring it out to all my ENT colleagues as well as the others that we have spoken through the entire day about obstructive sleep apnea having so many causes out here. And there's only one part of it over here, which is the obstructive part, which the ENT surgeon deals with. So no ENT surgeon in his right mind should be tom-tomming around the world even after he's doing so well, realizing that he is tackling only this part of it. And there is so much more, for which is why I've been talking about the multidisciplinary approach, because an ENT surgeon cannot do anything on these other parts here. He is still tackling only this part, but that part itself has evolved so much. So my strongest take-home messages to all the people listening in is that the ENT surgeon today becomes a very important part of the team. And I would say very important part of the initial primary evaluation of any physician. And even before a CPAP trial is given to the patient, an ENT surgeon should be brought in, because here's a video which will tell you why. Now, if you were to give a CPAP trial to a gentleman like this, you would be suffocating that person way more than you would be actually benefiting him. So you need to have a look inside the airway before you even plan a CPAP trial. And this is where the primary evaluation has to happen. So if you, I'm sorry for the quality of this image, this is a very old one of mine, but a very strong point which I deliver to everybody across, that even if you want to try a CPAP, please make sure that the CPAP is not going to suffocate that patient rather than give him benefit. And I say this again in the same manner, and I've underlined this here, that it won't be wrong to say that the ENT surgeon should be a part of the primary evaluation even before you offer a CPAP trial. And in that same breath, I go ahead and say that if the patient is primarily come to an ENT surgeon, then he must offer a CPAP trial before a DICE or a cine MRI is thought of. So it's a corollary both ways. It works both ways, where it's extremely important depending on where the patient has turned up. So the role becomes extremely important in identifying the site very meticulously, removing the obstruction, but I put that in a but, very well selected patients, not in everybody. Make sure you look at obstructions beyond the palate. And if you can't really do that much, at least help in improving the PAP compliance and downgrading the severity of that OSA. And my heartfelt gratitude to the people that I've learned from way back in the 2000s. Professor Richard Good from Stanford, he was the teacher to Riley and Powell, who have brought out the criteria. Professor Vicini from Italy, whom I've had the fortunate pleasure of having worked with him even as a faculty later on, and learned a lot of things. And I would end by saying, the more you know about sleep apnea, the more you realize how much you don't know. And the less you know, the more you think you know. That's why that ignorance is a bliss. So this is extremely important. And I'll end by one more small video which should tell you why it is so important to be multidisciplinary and identify everything correctly. And with this video, I will bring out that message that do not tackle OSA alone. It's a multifactorial issue and it's a multidisciplinary approach.
Again, cheers. Yes. Excuse me, madam. This might be the trick. Oh.
At Caltex, our staff will do whatever they can
Thank you so much. You're welcome.
to help make your life a little easier.
So I hope that was clear. They tried to help her by getting the oiling of the wheels done, but it was her knees that were creating the creaking sound. So thank you very much, everyone. And I'm open to discussions. Wonderful. And I must say, my apologies that I did not acknowledge the efforts by the National Health Academy in the beginning. So thank you very much from the National Health Academy and Dr. Nurul to get all of us together. I was taken in by Abhijit's comments and the discussion between Irfan and Abhijit, and I forgot to give my very big thank you to the organizers. Thank you very much.
Thank you very much, sir, for this very illuminating lecture. I know we have benefited a lot from it. Sir, one question that I would like to pose is the role for the importance of tongue-based surgeries in sleep apnea.
So it forms a very, very major part of the obstruction on the airway, but it is one of the most dangerous areas to tackle. So unless and until you have clearly identified the obstruction there, and unless and until you are well geared up to remove the obstruction, it is not for novices. It's not for the, I would say, a person who is not trained himself or taken the expertise in dealing with tongue base. So don't forget that even identifying the obstruction is good enough for you, and then make sure that you get yourself trained in it before you try to touch it, because that can be very dangerous.
Yes, sir. Thank you, sir. Thank you so much for giving us your time. I think we are due for a tea break of about 10 minutes, and we will rejoin at 4:30 p.m. for the panel discussion. Thank you so much.
Thank you.
So there is a tea break for say 10-15 minutes. By the time we are trying to webcast it on a YouTube so that it would be visible to most of the audience, those who have not even registered with us. We thought that this is a very important awareness drive, and we are making it accessible to all our viewers and all those who are associated with National Health Academy for long. So we are trying to make it on YouTube. So we are taking a technical break or say tea break. And
I would like to invite all of you all over for tea. Please
yes.
We'll have virtual tea together.
Yes, so the Zoom meeting is already on. Actually, it's a continuous functioning. Those who want to take any break, you can just put your camera off and mute it, and we'll join again after say 10,
those not
minutes.
Taking a break, and please let's interact with all the lovely, wonderful colleagues of mine and the people around.
Yes, you can.
There's a very interesting thing that I had in one of the webinars. I'm just going to share it with you on a lighter note. Mm-hmm. So the organizers were very innovative, and don't get me wrong, I'm not pointing to anyone. The organizers were very innovative, and we had a tea break, and before the tea break, an hour before, Zomato vouchers were sent to all the faculty and the registered delegates, because they paid for it and they were registered. Mm-hmm. And everybody sat in their places and utilized the vouchers and got their teas at home. Very innovative, I thought that was.
We'll try.
Actually, the same kind of a thing happened where everybody from the local, Domino Pizza, they were, attached, and every person who was attending from their Domino center, they were getting their pizzas. So these are innovative things, but fine enough. They are just,